You can understand. Just reached home half an hour back.
Yeah.
And
so Dr. Deepak is an avid runner. So he runs all marathons. And looks like he must have run also to reach office.
in morning only I had done 15 kilometers.
Okay.
Okay, I think it's already 3:02. We can start with everyone's permission. Dr. Ranjita, please हमारे Dr. Sandeep Sarkar को भी call कर लीजिए. He's the chair for the scientific session, first session.
I've messaged him. I'm going to call him.
Yeah, thank you. Let me share my screen. Warm good evening, everyone. Once again, welcome to the third episode of the third ICanCaRe International Oral Cancer E-Conclave, organized by ICanCaRe Foundation for Head and Neck Oncology, Sterling Super Specialty Clinics and Cancer Hospital, and Gujarat University, with support from TSI. We're extremely delighted that 2 Sundays have been absolutely fantastic and rocking, with immense learning and a different outlook to different set of topics. We saw how diagnosing oral lesions is very important in the right manner. We also saw on the second day how intervention care can be done with photobiomodulation and other aspects of cancer care. Today, we are going to see how quality of life can be enhanced using oral management practices for cancer patients. Today is also the third day for the quiz competition. So I invite all my viewers and my audience to stay tuned for the competitions which is ahead in this program today. I'm absolutely thankful to all the partnering organizations who have been tirelessly working with us throughout the entire week to make this really successful and to ensure that we have a wonderful learning academic sessions in the last 3 weeks. A statutory warning and reminder for all our audience and participants that please ensure that your microphones are on mute. The speakers will enable themselves and speak during the sessions. If you need to talk, just use the chat box to place your comments, questions, and feedback. If you have any more concerns, raise your hand, use the raise button on Zoom platform. Our moderators are going to get in touch with you and sort out the issues. This is being telecasted live and streamed live on YouTube and Facebook. And this is being also recorded. So we'll ensure, we request all our audience to please have the video on in the proper modes. We have the successful student paper competition for the first time organized at the E-Conclave, and it has been very, very successful. We had 15 papers who were shortlisted for the final review, and the rounds are over. The juries are assessing, and we're going to have the results out on 30th of April during the valedictory session. With this now, I invite the moderators for the scientific sessions of the evening. Dr. Shipra Deshpande, ma'am is a PhD scholar, Associate Professor of Oral Pathology and Microbiology at Hedware Dental College, Hingoli, Maharashtra. She's also a certified tobacco cessation specialist with us, has numerous publications to her name. Dr. Ranjita Ranjan, a dental surgeon with more than 10 plus years of clinical experience, an avid learner, and also a certified tobacco cessation specialist from Gujarat University. So I hand over the dais to Shipra ma'am first to continue the session further.
Shipra, kindly unmute, please.
Sorry. A very good afternoon to one and all. It's my pleasure to welcome you all on the day 3 of ICanCaRe Third International Oral Cancer E-Conclave. It is rightly said that wisdom comes not from age, but from education and learning. So to educate and learn, ICanCaRe organized this virtual platform in this month of April, which is again the month of oral cancer awareness, with the theme that do it, but do it right. I wish you a very productive conference with exciting and encouraging discussions and exchange of knowledge, so that together we can anticipate a future of groundbreaking knowledge and technology for humanities. For patients with head and neck cancer, where key functions are affected by both the disease and its therapy, the potential for an adverse effect for quality of life is considerably greater than other cancers. So with this attention. The theme for today's scientific session is oral management for quality of life for cancer patients. In this event, first, I would like to introduce our moderator for panel discussion, Dr. Manoj Tayal sir, who is presently working as a Director at Radiation Oncology, Max Super Specialty Hospital, Pratapganj, New Delhi. His specialty interests are total skin electron therapy, the volumetric modulator therapy, the brachytherapy. His best paper is in the reviewed journal, and he has more than 15 publications in reviewed peer-reviewed journals. He is a member of Association of Radiation Oncologists in and the ISRO, and he is also a member of FAG Manipal. So with this, we start with the first session of today's scientific event. First of all, excuse me, Shruti.
Yeah, we would like to first invite Manoj sir to kindly set the context and talk about the importance of the academic event today. Sir, over to you.
Okay, over to you, sir, please.
Thank you, ma'am. Thank you for the introduction. And now we are in the third day of our international E-Conclave, and it has been doing well. So day 1 and day 2, 3 had been very successful. Now we are in day 3. And now we are in oral management of quality, oral management for quality of life in cancer patients. So, cancer patients, their treatment is quite tough. Generally, when we are talking about, surgery or radiation therapy or chemotherapy, they have their own side effects. And, these side effects do affect the oral mucosa and, other mucosal linings of the body. But oral mucosa becomes very important in quality of life, because the thing starts from the oral cavity first. So our eating, our talking, all these things are related to oral cavity. So, anything which affects the oral cavity will affect the quality of life. So in management of cancer, we have to look at strategies, how to manage these issues, and to take the right decision at the right time, and how to prevent these complications, and we can improve the quality of life of this patient, because the buck doesn't stop at just at the completion of treatment, because the complications do happen even after cancer therapy is over. So then we should look at these issues, and when we want to bring the patient back to his normal life. So it is quite important, and this forum is the right platform to have all these issues to be discussed. And today we have very interesting talks in regards to the molecular pathogenesis of oral cancers and precision therapy. We have a talk on dental oncology, so which is an important part of oncology treatment, and the very important complications which are treatment induced xerostomia and mucositis. So we will have a special presentation on that. So I hand it over to Shruti to take it forward. So over to you, Shruti, and wish you all the best.
Yeah, thank you, sir. So, Shipram, I'm over to you to continue the scientific sessions, please.
Thank you, sir. Thank you, Shruti. So we'll start with today's first session. So the key speaker for the first session that is on molecular pathogenesis of oral. Just a minute. Molecular pathogenesis of oral cancers and precision therapy by Dr. Amit Verma, and chairperson for this session will be Dr. Sandeep Sarkar. It's my pleasure to invite Dr. Sarkar as a chairperson for this session, who is a MBBS MD and ex-senior fellow, Tata Memorial Center. You all warm welcome, sir. It's my pleasure to introduce our first speaker, Dr. Amit Verma, who is a MBBS MD and gold medalist from AIMS. He is a fellow of MD Anderson, fellow of Ramalinga Swamy Department of Biotechnology, Government of India. He is nominated as Padma Shri and is a global expert, peer-to-peer advisor given in precision oncology. Again, he is a founder and director of Dr. A.V. Institute of Personalized Cancer Therapy and Research. Presently, he is working as a Chief Medical Director, MIQ Laboratory, India and United Kingdom, and Chief Scientific Director, Promec Limited, United Kingdom. Welcome, sir. Over to you.
Thank you very much for the nice introduction, and I thanks Dr. Pawan for inviting me as a speaker in this esteemed conference. And I would like to share my screen. And is my screen visible to everybody?
Yes, sir.
Yes,
Absolutely.
yes, sir.
Okay, all right. Perfect. So today, the topic which have been assigned to me is very interesting, and I'm going to talk about the molecular pathogenesis of oral cancer and the newer precision oncology approaches in head and neck cancer, and the way we are currently practicing, especially in the metastatic setting. So we understand the burden of the head and neck cancer, and which has already been discussed in the past few, you can say, days. And I understand that everybody is focusing on to getting the best treatment for the patients here. But I would like to emphasize that the important risk factors, which we are already well aware of, tobacco and the alcohol, the human papilloma also plays a very important role in oropharyngeal cancer. And we'll just see what is the difference of the molecular pathogenesis when we compare the tobacco-associated cancer versus the HPV cancer in the subsequent slides. The reason why we want to understand at the molecular level is something to identify who are the patients at risk who have not developed cancer yet, who may get benefit from the chemo prevention, what are the possibilities or the incidences of the transformation of a pre-malignant lesion to a frank primary. The molecular signatures, whenever we study, they can give you some answers in terms of prognostication as well as the therapeutic targets. There are certain recent studies which talks about TP53, cyclin B1, CDKN2A as a possible prognostic biomarker, and also FGFR1 amplification as a possible therapeutic target is being discussed. So let us understand the basis of the molecular model of oral carcinogenesis. And we understand it is a step fashion pathogenesis into frank malignancy, starting from the normal mucosa to the hyperplasia to dysplasia, which can be of three types: mild, moderate, severe, and the frank invasive malignancy. And here you can see there are certain events which are early events, 3P and 9P, which are early events, and 9P deletion have already been reported as one of the mechanisms or prognostications in terms of the poor prognostications and the predictions of transformation from hyperplasia to dysplasia. And in subsequent alterations in different locations of the chromosome, like 17p4q, and then these other alterations can lead to the invasive malignancy. So depending upon whenever we do an analysis of a sample and do the molecular signatures, we try to understand what exactly is the molecular grade of the dysplasia and how quickly is going to be the transformation, soon or later. So let us try to understand the basis of the pathogenesis, that is the interplay of oncogenes and the tumor suppressor genes. And we understand that once the proto-oncogenes are activated and forms oncogenes, or inactivation of tumor suppressor gene leads to all these alterations at the histological level, actually. From the transformation of normal epithelium to the hyperplasia, the early event is the TGF-alpha overexpression, which interacts with the other biomarkers like EGFR, which are also overexpressed And this can lead to this transformation of hyperplasia into dysplasia. And then subsequent alterations like KRAS or the APC gene inactivation can transform the dysplasia into carcinoma in situ. And then the frank malignancy happens at the level of p53 inactivation. So we have to understand that the p53 is a late event and TGF alpha or EGFR expression is an early event. Once the frank malignancy is set in, the possibility of metastasis or the potential of metastasis depends upon downregulation of various markers like E-cadherin, which is involved into cell-cell addition. Once it is lost, the chances of metastasis goes up actually. So this is an interplay of so many genes, which is in a step-like fashion and the tumor and the normal epithelium is transformed into a frank malignancy. So let us talk about the important oncogenes involved in the oral pathogenesis. Starting from the growth factors, that is TGF, or fibroblast growth factor, or platelet-derived growth factor. These are the three important growth factors involved in the pathogenesis. The surface receptors, that is the EGFR or the FGFR, and the subsequent pathways, which are downstream pathways of EGFR, are involved based on the activation of these oncogenes. The RAS pathway, and then the oncogenes like MYC, FOS, and JUN, which are nothing but transcription factors, which leads to the activation or overexpression of various other genes involved in the pathogenesis. And then we have cell cycle protein, cyclins, and cyclin-dependent kinases, which are altered in this tumorigenesis. Also, inhibitor of apoptosis, that is BCL2, is seen altered in the pathogenesis of oral cancer. There are three biochemical mechanisms of all the oncogenes taken together. Either the oncogene is activated by, or it activates the downstream proteins at the level of serine, threonine, or tyrosine as a substrate. The signals from the receptor to the nucleus can go through the transmission by GTAPases, like what we see in the KRAS alterations. The transcription can be regulated at the level of DNA by the genes which I mentioned, MYC, JUN, and FOS. So at the molecular signature, we normally see the head and neck cancer have the EGFR gene overexpressed or because of the gene is amplified. And I just mentioned that this is an early event. Again, the aberrant expression of TGF alpha and TGF beta, which associates with EGFR and SMAD2, SMAD3 respectively, leads to the pathways activation, causing the transformation. Again, the GTPases signals are caused by the activation of KRAS and HRAS, which is normally seen to be mutated at the codon 12, 13, and 61. In head and neck cancer, we see more commonly HRAS, not KRAS. KRAS is commonly seen in pancreatic cancer, colon cancer, or the lung cancer. But in head and neck cancer, the change what we normally see is dominated by the HRAS. But the location of the mutation is same in all the KRAS or the HRAS, that is 12, 13, and 61. In terms of the tumor suppressor gene, T53 is a late event, as I mentioned, and this is the important tumor suppressor gene defect which happens in the oral pathogenesis. We can have three patterns of mutations in T53. One is the mutations leading to loss of function. Once this alteration leads to loss of function, this allows the tumor to pass through the G1S boundary and propagates the genetic alterations that may lead to activation of other oncogenes or inactivation of other tumor suppressor genes. The TP53 mutation can also have an effect, what we call as dominant negative effect, where the mutant P53 can antagonize the wild type P53 and its activity, and it can suppress the wild type activity in a dominant negative fashion. The third alteration or type of alteration, what we normally see, is called gain of function in T53. We understand that T53 is a tumor suppressor gene, but once they have a gain of function, they behave like oncogene actually. So this is something which we should be familiar with. As I was talking about the viruses HPV, we understand there are plenty of subtypes of HPV associated in oral cancers, especially the 16 and 18, which is the common one. But others like 2, 6, 11, 31, 33, 35 are also associated with the transformation from dysplasia to squamous cell carcinoma. So the role of HPV, what we understand is HPV is a circular double-stranded DNA structure which integrates with the normal epithelium genome and can lead to the expression of E6 and E7 protein, which degrades the 53 or retinoblastoma respectively, and can lead to the cell cycle dysregulation. And this is the mechanism of the HPV-associated cancer. Interestingly, we do not see much of genetic alterations in the HPV 53 or retinoblastoma, but it is the direct effect of E6 and E7 protein what we normally see. So that's a very interesting thing, that when you do a genomic testing in these cases, you will not find 53 alterations or retinoblastoma alteration, but at the level of expression, that is at the level of protein, you may see loss of 53 in these cases. So let us try to compare the HPV negative pathways and the HPV positive pathways. As I mentioned, that in HPV negative, that is the classical head and neck cancer, what we normally see, the dominant pathways are DNA repair pathway, that is P53 dependent pathway, seen in 72% of the cases, followed by cyclin or cell cycle dysregulation alterations in CDKN2A, B genes, or cyclin D kinases. So these are dominant pathways seen in the head and neck cancer, which are HPV negative. On the contrary, you will see that the dominant pathway in the HPV positive is the PIK3CA mTOR pathway, which is seen in 48% cases, and P53 or the cyclin D1 is practically not seen in these, or very less seen in the HPV associated cancer actually. So this is a major difference in the pathways in the HPV positive and HPV negative. And these alterations are also a potential for us to target them, as we understand that we have PIK3CA, P10, AKT, mTOR pathway inhibitors available these days, which we can use for our patients who fail the conventional treatment actually, but it is under the clinical trial setting as of now. So let us talk about the precision oncology in cancer care. We have moved from the one drug fit all approach to one patient group, one biomarker, and one drug approach in most of the cancers, especially lung cancer these days. We are now moving towards one patient, one tumor profile, and more options, which is based on the combinations of various target therapies or in combination with immunotherapy. So this is the newer version of treatment, what we are applying these days in the various different settings actually. So recently, a few years back, a drug called tipifarnib was approved by US FDA for HRAS positive head and neck cancer. And they say that the VAF of HRAS, if it is more than 20%, and the patient have progressed on the standard chemotherapy, platinum-based chemotherapy, they are eligible for using this tipifarnib in a recurrent or a metastatic setting actually. So these are the therapies which we can apply, but we need the molecular biomarkers to study those things. So even in the NCCN guidelines, which I have just talked about, the salivary gland tumors of head and neck, they have talked about various biomarkers like androgen receptors, NTRK, HER2, and the biomarkers like MSI high or TMB high, BRAF alterations, RET alterations. For all these alterations, we have drugs. We have drugs which we can apply, and these are in a precision oncology fashion. And so what we need to do is to analyze the patient at the molecular level and identify what kind of molecular signature is present in the patient. And then we can apply the various other target therapies or immunotherapy for that matter actually. So FDA have approved immunotherapy, that is pembrolizumab, for the first line treatment of head and neck squamous cell carcinoma. And they say that pembrolizumab can be used in combination with the chemotherapy, that is platinum and 5-FU, for all patients in first line setting, or as a single agent for patients who's expressed PD-L1, which is a biomarker for response to the immunotherapy when the PD-L1 CPS score is more than 1. So let us try to see something beyond what the FDA has talked about. There is a somatic copy number alteration, that is the 9p loss is seen, which we have discussed in the first initial slide, that 9p is an early event. This alteration in an HPV negative head and neck squamous cell carcinoma dictates that the tumor environment is going to be cold type, and the immunotherapies, that is PD-1 checkpoint inhibitors, will not work that great. So though the biomarkers are coming in a great way, but we are learning more and more, and we are identifying who are those patients who are eligible as per the guidelines, but will not show the responses when you do the molecular testing in those cases. So I would like to give you a real life example, which was a case seen in 21. And this is a head and neck cancer, which is metastatic head and neck cancer. And patient underwent a comprehensive genomic profiling using a 324 gene assay with various biomarkers like TMB and MSI. And these are the biomarker findings which were observed in the patient. Here you can see that the CDKN2AB is truncated, and this is called CDKN2AB loss. We also have a gene that is called MDM2 amplification. MDM2 amplification is leading to the loss of TP53 function. Again, the patient have a TP53 alteration, and other pathways like Notch and SF3B1 is also altered in this patient. So if you just see this genomic profile and the pathways involved, you can tell that this is a HPV negative associated pathogenesis, as TP53 and CDKN2A is seen in this patient. But we also have to understand that CDKN2A is a gene which is located in the same area, that is 9p arm of the chromosome. And this loss, which is seen over here, is basically a biomarker for poor response to immunotherapy. Even if the guidelines talks about that immunotherapy can be offered to these patients, but genomically we can predict that these patients may not get that benefit even if we use the immunotherapy. Further, the biomarker like MDM2 amplification is known to show hyperprogression in cases when you use immunotherapy. So rather than getting the benefit, it will be detrimental for the patient to receive immunotherapy, and you may end up having progression rather than response. So these are the beauty of these signatures. Once we understand, we can predict the real outcome, prognosticate them, find the therapeutic options, whether any resistance mechanisms for the available therapies. So with that, I thank you for your kind attention, and over to the organizers for questions.
Thank you, sir, for such an informative presentation. Actually, being an oral pathologist, molecular pathogenesis, I think it's a work of patience, and hats off to you, sir. You are doing very nice on this, and it was a very good presentation. It's time for chairperson's remark. I invite Dr. Sarkar, sir, to give his remark.
Thank you, Dr. Amit, for such a wonderful talk. And being as a radiation oncologist, we treat a lot of oral cancer patients, especially in this region of Uttar Pradesh, Bihar, and Kolkata, West Bengal. We get a lot of oral tobacco use patients comes with the oral cancer patients. Highest number head and neck cancers we get, especially tongue and buccal mucosa cases. So thank you, and we can see future through you. This we have a lot of new molecules will come in future, will help us to treat the oral cancer. Thank you so much. Thank you, everyone.
Thank you, Sandeep. Thank you.
Thank you, sir. Thank you, sir.
Thank you.
So we'll move on to our next session, which is on dental oncology and integral part of oncology treatment by Dr. Sudha Shah. And the chairperson for this session is Dr. Asim Mishra, who is MS, MCH and head and neck surgery. He is trained in head and neck surgery at Tata Memorial Center, Mumbai. He has more than 11 years of experience in field of head and neck surgery, oncology. He has more than 60 publications in a peer-reviewed journal, and he is involved in randomized controlled trials associated with the neck, head and neck oncology, and is working actively and is involved actively in training residents in head and neck oncology. His area of interest is head and neck surgery, skull-based oncology, cancer screening and control for cancer, and the awareness for cancer. Presently, he is working as an associate professor and in charge head and neck oncology, Tata Memorial Center, Varanasi. A warm welcome to you, sir. It gives me immense pleasure to introduce our next speaker, who is Dr. Sudha Saha. She is BDS and FAD from Germany in 1998. Madam is passionate for aesthetic dentistry. At the same time, she has worked in the Cancer Institute. She has also done observership from AIMS Kochi in clinical oncology. She is also a Tobacco Cessation ambassador. Her mission and vision is to be the pioneer in cancer cure and research through innovations to give better quality of life to the cancer patients. It's over to you, ma'am. Welcome.
Thank you, madam. Good afternoon, friends, colleagues, and dignitaries. It's a pleasure to be a part of the platform. How can I share the screen, madam?
Ma'am, there is screen share option.
Green. There's a green button. Share the screen.
Share screen.
You might have already opened your PPT.
Yes.
Okay. Go to screen share option and you will able to share this PPT.
Yes. Is it visible?
Yeah. Yes, ma'am. Yes. You go on the slideshow. Yes. Okay, fine.
So, So hello, my dear friends. Today topic which I'm going to speak is dental oncology, which I feel is a very important part for the quality of life for the cancer patients. I'm going to speak about my evidence-based protocol for the cancer patients, which I feel will improve the quality of life and the completion of the treatment smoothly for all the cancer patients. So all of us know that oral health and hygiene plays a very important role in the comprehensive management of cancer. So, but here the goal is only to prevent infection. It can be a dental abscess, which can be a lifesaver to follow the protocols for managing oral side effects of chemotherapy and radiation therapy. So we know this is the era of target therapy, immunotherapy, and chemotherapy. So a range of, so what are the oral care to be taken and what is the risk assessment in the dental treatment? A range of chemotherapeutic medications are prescribed in the battle to contain and remove the cancer cells. Their aim is to damage DNA so that it results in the death of the malignancy. The challenge for us is the effect on non-malignant cell population. So we have to understand that how we can play the role in that. Our ability, we have to identify the patient that who are at risk of more complications, more toxicity. So that way dental oncologists can play a very important role. Whatever it is, there will be oral toxicities which happens with the target therapy, immunotherapy as well, which impacts the oral care, which let the patient not use the oral prosthesis, which affect the pharyngeal function like speech, mastication, diet choice, swallow. So we need to attend to these oral toxicities so that the patient is having the quality of life and the patient is able to finish the treatment. In my practice, I have seen that periodontitis plays very important role. If the periodontal condition of the patient is not good, the grade of the mucositis is more. So we need to take care of that part. Oral immuno related adverse effects, adverse events, lichenoid reaction, bullous pemphigoid, dry mouth, taste change, stomatitis, glossitis, all these can be attended symptomatically. Oral adverse event of immune of ICI are xerostomia, oral mucosal disorder, taste change. All of these also happen with these medications. Tend to it. In head and neck cancer patients where there is mucositis, where the patient is under radiation therapy, there will be ulcerative mucositis, which 85% of patient faces. So severity and is more if the chemotherapy is given. So if we are going for any dental treatment or any dental care, we need to see the dosimetric curve, which will be made for the patient specific. We should be aware of that. So why does the toxicity happens? There will be oral health and oral hygiene where we can play a role. Oral microbiome, saliva function, these things we can play a role and then take care of the part. Disease status, myelosuppression, immunosuppression, treatment related factor, these will be there, but the other parameters will be able to take care of the part. The targeted therapy, targeted agents like EGFR inhibitors, cetuximab, it also causes mucositis, which is more with which is more the anti-VEGF bevacizumab. This also it leads to bleeding. So when we are doing the dental treatment for a patient, we should be aware of that. It also leads to osteonecrosis. TKI inhibitors, sunitinib and sorafenib, these also leads to the necrosis. So we should be aware of that and then do a dental procedure. mTOR inhibitors also causes stomatitis, lichenoid reactions. So above all other targeted agents, though they are targeted, but they have their side effects. TK inhibitors also causes neutropenia, thrombocytopenia. So whenever we are doing any dental infection, we should be aware of that so that we are able to attend to it as required. The oral toxicity will be impacting the quality of life. It increases the resource use, which is a important thing which we have to keep in mind. The cost will increase, the admission will increase, the medications, the treatment plan will be affected. So if we have a control on the oral hygiene, that I feel that plays an important role. The osteonecrosis. Nowadays, there are medications, as I told you, which causes osteonecrosis. So as all of us know that it is a degenerative bone condition characterized by death of cellular component of bone owing to interruption of subchondral blood supply. So in osteonecrosis, there will be a bone exposure, there will be a dull ache pain. So I have done a retrospective study on 2,000 patients in 3 years. My main motto was to estimate the incidence of medication-related osteonecrosis of the jaw in cancer patients. I wanted to use C-terminal telopeptide biomarker, which nowadays it didn't give me also any result, but I wanted to see that how it works. OPG and dental evaluation. I also wanted to formulate the possible protocol in our hospital to prevent MRONs and to provide more effective management. And also wanted to determine the association of MRONs to therapy, duration, and modalities. So I did the study. This is the C-terminal telopeptide cross-link biomarker, which was given by Marks in 2000. When it was told that if CTX value is less than 100, there was high chances. If it is 100 to 150, moderate. If it is greater than 150, it is minimum. And the OPG finding, as all of us know. So the prevalence of osteonecrosis in cancer patient with bisphosphonate range from 1 to 10%. So I saw for all the patients who were on skeletal meds and multiple myeloma cases. The skeletal meds, that is with the breast, prostate, and lung cancer. That was the, this is about the bisphosphonate. The thing which we should know about it is that half-life of bisphosphonate is 11 years. So once it is given, the chances of necrosis is maximum. Of course, intravenous. So the renal clearance is only for 30 to 40%. So remaining 60 to 70% are absorbed, are bound to the bone. So we have to be very careful if the patient is under bisphosphonate. These are the drugs which causes necrosis. As I told you, the IV bisphosphonate, that is zolidronoric acid, pamidronate, ibudronate, these are the oral bisphosphonate. Also, sunitinib, sorafenib, which are given, bevacizumab, and denosumab, which is a human monoclonal antibodies. These are the medicines which causes necrosis. In the 2000 cases, I found in 3 years that the rate of osteonecrosis was maximum in multiple myeloma cases, and then goes the breast cancer and prostate cancer and others. So in the 2000 patients, 500 underwent a dental treatment, in which 400 went a routine dental treatment and 50 went for dental extraction, and others went for the root canal. So in this 20 patients of 500 suffered from bronze, bronze medication related. So 14 patients recovered with a conservative treatment only, with the antibiotics, with the care. With the care only it recovered. We use the antibiotic of clindamycin, tetracycline, depending on the condition. In this, out of 20, 14 patients recovered, and there were 6 patients who had persistent bronze, 1 lost follow-up, and then 2 expired, and 3 are on follow-up. So here we found that the maximum of the patients were women, 60% were women, and then mandible 65% and maxilla 27% was found. Among the malignant condition, multiple myeloma accounted for the majority, that is 43%, and metastatic breast was 32%. So I mean to say, and then 67% if there was a dental extraction done, and 7% if there was a denture or pressure sole. CTX didn't give me any specificity or sensitivity, so I didn't include it further. I wanted to tell that the conclusion part, which is most important, that is prevention is better than treatment, and the establishment of meticulous oral hygiene and surgical procedure prior to commencing bisphosphonate treatment is important for preventing bronze. So we have to be very active when the medications are going to lead to a necrosis. So when I was doing the retrospective study, I found that 0.8% of necrosis was found in first year, 2% was found in the second year, and 2.8% in third year. And as I told you, multiple myeloma, it was more as compared to the other. So we again play an important role in managing the care of the patient with bisphosphonate or the medication associated to osteonecrosis. This is a patient whose necrosis is there in the maxilla. She has come from Libya, underwent extraction. This is the OPG of the patient. Now just she has come, she's on follow-up with us. This is the 3D CBCT images of the patient. If we talk about osteoradionecrosis, how does we play important role in that? It is the, as all of us know, it is the late complications for head and neck cancer patients. And again, it is a non-healing area or exposed bone in the mandible or a maxilla. What is why does osteoradionecrosis happens? It's again because of the poor dental and oral health, post-radiation dental extraction, and radiation dose. If the radiation dose is greater than 55 gray or 65 gray, the high chances of necrosis is there. I have also seen if the patient is on smoking, alcohol use, if there is proximity of tumor to the bone, nutritional status leads to osteoradionecrosis. So prevalence, I have seen that in conventional, it is 7.4%, IMRT, it is 5.2%, and if it is with the chemotherapy, 6.8%. So majority of cases, if it is the treatment, radiation is given in the oral cavity, the mandible is affected. If it is for the oropharynx and all the maxilla is more affected. I didn't find anything much in pentoxifylline and tocopherol, though I have been using it as a protocol. Trismus, as all of us know, it's a tonic contraction of the muscles of mastications, which affects the quality of life. Now the radiation therapy IMRT has come, which help to improve the quality. Earlier, the conventional radiation therapy, it was 25.4%. So here again, if it is with the chemotherapy, if radiation therapy is with the chemotherapy, the prevalence is 30.7. So here again, we play an important role by helping the patient for the mouth opening exercise. In our hospital, whatever patients are going for radiation therapy, we call them weekly to see that they are doing the mouth opening exercise as they get abandoned and they don't want to do it because of the pain. Xerostomia, it's again a late side effect of the radiation therapy, which we need to address it. The prevalence is again, if it is conventional, it is a late side effect. So greater than 2 years, we can see 91%. But now IMRT used, so xerostomia percentage has reduced to 68%. So management is that radiation therapy if given by parotid sparing IMRT. Pilocarpine is also used for the treatment, but if there is fibrosis in the gland, it doesn't work. We can use oral mucosal lubricants and saliva substitutes. This is a late side effect, which is called as radiation-related caries, which is a radiation therapy either used alone or in combination with surgery or chemotherapy is the most important modality for treatment for head and neck cancer patients. So patients undergoing radiation therapy usually experience significantly early and late onset toxicity and adverse effect. Radiation-related caries is common complication that determinantly affects the patient's quality of life. So a clear understanding and more uniform approach to scoring system help provide a more accurate diagnosis, form treatment protocol, plan and evaluate the outcome of preventing and initiating a creative scientific database. Many indices has been given to assess and quantify the dental caries. So there are one post-radiation dental caries by Walker et al. But now we are practicing DMFS 160 by Watson et al. This is a indices which is given. So this is a more accepted what I feel, because here the 5 surfaces of the 32 teeth are used. This is the OPG of the radiation-related dental caries. This is the clinical picture. So this is the radiation induced dental caries, radiation-related dental caries. We divide it into a stage and grade, and depending on the stage and grade, there is a treatment planning. So stage 1, when there is early decalcification, chalky white or brown decalcification. Stage 2, if cervical decay or incisal cusp tip decay. Stage 3, if enamel delamination. Stage 4, if crown amputation. So grades are there. Grade 1, if it is less than 25% of teeth is affected. Grade 2, between 25 to 50. Grade 3, between 50 to 75. And grade 4 is greater than 75%. So according to the stage, there are the treatment plans. If it is stage 1, how should we go about fluoride application and oral hygiene maintenance? If it is stage 2 and grades, we can go for fluoride application, plus there will be a restoration, plus we can go for a endodontic treatment. So the same way it is for stage 3, stage 4. So this is the main summary which we all should know as a dental oncology. How do we play an important role in all the cancer patients? If it's head and neck cancer patients, the oral prophylaxis should be done before the surgery. If there are any loose tooth, we should extract, because during and we should extract it during surgery, because during intubation that loose tooth may be a problem. Before radiation therapy, the teeth which cannot be salvaged are extracted, the teeth which can be restored are restored, and then we go for a fluoride application. It can be a varnish or and tray, whatever is there. This is before radiation therapy. After radiation therapy, we go for a follow-up protocols every 3 months, protocol for at least for 5 years, so that the patients are taken care, their oral hygiene are taken care, they know how to take care, their mouth opening exercise, everything. When the cancer is with bone mets, is it when they all the cancers which are involving bone mets, and then that time we need to extract the tooth, which we can't save it. If the patient is in the condition bedridden, then we need to be on follow-up, take care, give a drug holiday and remove the tooth. Multiple myeloma, again, all indicated extractions are carried out and sufficient healing of extracted tooth is ensured prior to the induction of bisphosphonate. If the cancer patient is with multiple mets, again hygiene maintenance and management of acute dental infection is very important. Renal cell carcinoma, as I told you, tyrosine kinase inhibitor like sunitinib and sorafenib. So again, we need to remove the teeth before initiating these medications. Routine dental care for all the cancer patients is very important. Oral hygiene maintenance such as oral prophylaxis, deep cleaning of gums, cavity restoration, root canals, extractions of severely decayed tooth, and rehabilitation of prostheses. Patients are encouraged to be on regular follow-up to prevent the serious infection. But if the patient is on bone marrow transplant, again the tooth which is the source of infection has to be removed. Again, all of these patients always should have a prior OPG to have data. How can we take care if we are not able to take care before the treatment? I know these things are possible only when if there is a connection between the medicine and the dentistry, or rather to say that between the dentist and the oncologist. So this is quite slow paced in our setup. So if we are able to work on this, the quality of the life of cancer patients will be good. Thank you.
So,
Thank you.
Thank you, Dr. Sudha, for the talk.
Thank you, ma'am. It's time for chairperson's remark now.
So definitely the role of dentist is very important, especially in oncology patients, because it not only affects the outcome in terms of quality of life, it also affects the quantity of life, that is the survival. So whenever there is any oral ulceration post radiotherapy and there are development of the osteonecrosis, and if it is not managed timely, that leads to severe complications, even fracture of the jaw, and at times you have to resect the mandible when there is a severe osteonecrosis. So all these points that you have elaborated, it's wonderful, and this is a very important topic. And every patient that is being managed for cancer, this needs to be sent up for a dental workup, so that we are able to catch up these complications and avoid these complications, because all of these are very much avoidable.
Yes, thank you.
Yes, sir. Very rightly said. Thank you very much, sir.
Thank
now
you.
I hand over to Dr. Ranjita for further proceedings.
There are many questions coming up. I think Sudhaji and Asim and others, if they can stay back for the panel discussion, so that we can answer some of the questions in the chat box. Right, some patients. Thank you.
Yes.
Thank you, sir.
ma'am.
Thank you, ma'am.
Now we have come for a scientific session third. So for this third scientific session, we have with us chairperson Dr. Deepa Joseph. Welcome, ma'am.
Thank you.
She's a additional professor in Department of Radiation Oncology, AIMS Rishikesh, MBBS, MD, DNB, IDEA Award, Conquer for Cancer Foundation 2019, International Innovation Grant by an International Innovation Grant these
Jita, any problem? Shall I continue?
No, it's okay. It's okay. International Innovation Grant by Conquer Cancer Foundation 2021, Traveling Fellowship by ESMO, and vast experience in radiation oncology got multiple national and international publications. It's immense pleasure to introduce our speaker of this session, Dr. Anshul Jain, BDS, MDS, ICOI Spain, CTCS Gujarat University, oral and maxillofacial surgeon implantologist, presently associated with Max Hospital as consultant in Department of Head and Neck Oncology. He is the one of the executive committee member at IDA Trans Hindu branch, heading the post of editor. He is executive committee member of AOMISI Dental NCR chapter. He is the director of Brush 32, a complete dental and facial care, along with consultant at multiple dental clinic and hospital in Delhi NCR region. So welcome, ma'am, Deepa Joseph ma'am, and welcome, Dr. Anshul. Over to you for the session.
Thank you, Dr. Anjita. First of all, I would like to thank the organizing committee for choosing me to present the presentation. So I will just start up with the presentation. I'm just going to brief out the same things which Dr. Sudha has just told us, everybody, very elaborately. So my topic is for the clinical management of treatment-induced mucositis and xerostomia and radiation-induced trismus. So first of all, I would like to differentiate about all three of them: oral mucositis, xerostomia, and trismus. They all are interlinked to each other, but have different features separately. Basically, oral mucositis is the erythematous and ulcerative lesions of the oral cavity. If we go for xerostomia, it's a feeling of dryness of mouth due to decreased production of saliva in the mouth. And trismus, as we all know, is the reduced mouth opening. So first of all, about the oral mucositis, according to the WHO, it has been classified into 5 grades: grade 0, grade 1, 2, 3, and 4, depending on the severity of the mucositis. Grade 0 is when there is no mucositis present. Grade 1, when there is erythema and soreness present inside the oral cavity. In grade 2, there is ulceration, but patient is able to eat some solid food easily. In grade 3, basically ulceration will be there, but patient is able to take only the liquid diet and not the solid food.
Excuse me, sir, your slides are not moving.
Is it not visible?
No, it's visible, but it's not moving. You
Get in the presentation mode.
On the presentation mode, and then it will be.
It's in the presentation.
Just full presentation.
Sir, full screen presentation.
उसमें 3 dots दिख रहे हैं, 3 दिख रहे हैं, उसमें से third वाले
slide presentation.
Yes.
Is it visible now?
Yeah, just press that. Again, no, it's not in the presentation mode. Just press that third
Is
button.
it is visible, but it's not showing. Next slide. Sir, it will show in presentation mode.
किसी को press करो.
In my screen, sir, it is showing in the presentation mode.
It is not showing. Otherwise,
no, sir, it is not on slideshow, sir. Good afternoon.
off करके on करो फिर से मतलब बंद करके फिर से start. Again, do a reshare in the presentation mode.
Dr. Anshul, if you want to drop it in the group, you can just drop it in the group. I'll share it for you.
Yeah, sure. Just one second.
Yeah, now it is okay.
Now it's okay.
Now it is fine. Now it is fine.
Yes, sir. Thank you.
So, grade 3 is ulceration with liquid diet intake. And in grade 4, patient is not able to take the liquid diet also. So we need to go for rice tube and any other feeding procedure method for that. Other classification is by the Indian Society, National Society of Cancer, in which they have basically divided it into two categories: the clinical examination and the functional or symptomatic classification. Both of them have 5 grades in it. In the clinical examination, grade 1 is the erythema of the mucosa is present. In grade 2, there will be patchy ulcerations with pseudomembranes present over it. In grade 3, there will be confluent ulcerations with bleeding with minor trauma when we palpate that area or check that area clinically. In grade 4, there will be tissue necrosis with spontaneous bleeding into all sites, which can be life-threatening. And grade 5 will be ultimate death. And for the functional or symptomatic conditions, in grade 1, there will be minimum symptoms with patient having normal diet. In grade 2, there will be symptomatic, but patient can swallow and eat moderate diet like liquid or semi-solid diets. In grade 3, patient won't be able to have that semi-solid diets and had to take hydrate orally only. In grade 4, it is a life-threatening, like in clinical examination, patient is not able to have its normal food or liquid diet also. And grade 5 is death. So if we go for the management of oral mucositis, there are mainly 6 categories in which we can go for the management. First of all, like if we go for the pain control, we can have analgesics for that thing to give initial temporary pain relief to the patient. Along with that, we can go for topical anesthetics to give the temporary relief to the patient. And we can go for sucralfate also, which reduces the pain of the oral cavity. Along with that, in nutrition support, that is a very important aspect for reducing the oral mucositis, that the patient should have continuous soft and cold diet, soft and liquid diet, if in case they are not able to chew their normal food, so that the body nutrition should be balanced properly. Oral decontamination, that is also a very important aspect for the treatment of oral mucositis, as maintenance of good oral hygiene is very important. Along with that, it also reduces the risk of any systemic diseases, sepsis, basically, if in case we do the proper oral decontamination. Management of oral bleeding, in case we feel we see that there is any oral bleeding present, we can reduce it, stop it by fibrin glues or any hemostatic agents applied over that area. Along with that, palliation of dry mouth, that Dr. Sudha has also told, is very important, which ultimately leads to xerostomia. We can advise patient to have regular sip of water intake as much as they can. Along with that, they can have chewable sugar-free gums, so that which increases the salivation of the mouth. And therapeutic interventions mainly includes the cryotherapy, which is nowadays very less used in this aspect, but it has a very good result for the patient to give the relief. Other than that, we can use growth factors, administer growth factors for that thing to give the relief to the pain in oral mucositis. And we can give antioxidants to the patient, or low-level laser therapy can also be an option to give the therapeutic intervention for oral mucositis. Now we come for the xerostomia. It is basically divided into grades of mild, moderate, and severe, depending on the salivary flow of the oral cavity, which is generally in between 0.2 to 0.7 ml per minute, which total counts out for around 500 to 1.5 liters in a day. If in case the patient is having less than 0.2 ml per minute, more than 0.2 ml, then we called it as a mild xerostomia. If in case it is less than in between 0.1 to 0.2 ml, then we call it as a moderate, and severe is less than 0.1 ml per minute. According to the salivary flow, the treatment is dependent on that thing, that how we need to proceed out for reducing the xerostomia. Other factor by RTOG system is that grade 1 is there is slightly thickened saliva. It is basically dividing it into acute and chronic depending on the time period of the radiation therapy. Grade 1 have slight thickened saliva with additional fluids which may be required to increase the salivation. And in chronic condition, there will be a slight dryness of the mouth. But patient can respond to the stimulating factors like artificial or normal stimulating factors for that thing. Grade 2 will have thick, sticky saliva, and we need to alter the diet for that condition. In chronic condition, there will be moderate dryness of the mouth with a poor response to the stimulations of salivation. In grade 3, there will be inadequate oral nutrition related to the salivary gland changes, which happens after post radiation. And in chronic cases, there will be complete dryness of mouth. In grade 4, which is the most severe condition, in which there will be acute salivary gland necrosis, which leads to complete dryness of mouth and can lead to fibrosis also. Now, on the management of the xerostomia, the first and foremost is the strengthening dental and oral hygiene maintenance, which is the most important thing to be maintained to maintain the salivation of the mouth. Along with that, restoration strategies for salivary gland functions is very important, in which sialogogues are used to increase the salivation to induce more salivation in the mouth. And there are other methods also, like electrical stimulation can also be used, which is known as salitron, for increasing the salivation of the parotid glands. And mechanically, we can increase the salivation by giving the chewable gums to the patient, multivitamin capsules or lozenges for that thing, so that it can stimulate more salivation. Along with that, acupuncture is also an important thing, which helps in the salivary stimulation of the parotid glands, and which gives good result also. Salivary gland sparing radiation techniques are nowadays used a lot to reduce the effect on the salivary glands by using intensity modulated radiotherapy or the proton radiotherapies, which basically reduces the effect on the main gland and effect directly on the necrosed tissues or the cancerous tissues. Radio protection, that is also an alternative for reducing the xerostomia. Like amifostin is the best medication for that thing, which can be used during the radiation therapies to reduce the chances of xerostomia. Campol is basically a stable nitro oxides, which increases the stimulation of saliva in the glands. Or multiple salivary substitutes, as I have already told, can also be used for reducing the xerostomia. About the trismus, it is divided into 3 stages depending on the mouth opening of the patient. That is, if it is greater than 45 mm, then we call it as stage 0. Stage 1 is restricted to mouth opening of 20 to 44 mm. And in case it is less than 20 mm, then we call it at stage 2 trismus of the oral cavity. For the radiation-induced trismus, basically it can be because of multiple reasons. Like if in case the tumor has invaded into the masticative muscles and we need to excise during the surgical procedure, then this also can lead to trismus. Along with that, in case we are going for the radiation and chemotherapies or surgery, including the radiation therapies, and other chances will be like if there is any dental cause or dental infection. Along with that, if radiation therapy has been given, then it can lead to the trismus. The basic how it happens is that there will be the activation of the inflammatory cells, which leads to the pro-inflammatory activation of pro-inflammatory cytokines and biomarkers, which ultimately leads to the hypoxia and fibrosis of the muscular structure over that area, and persistent systemic inflammation, which ultimately induces the trismus over that in the oral cavity. These are the guidelines by the Tata Memorial Hospital. Basically, they have divided the treatment of trismus, the radiation-induced trismus, into 3 parts: the normal supportive therapy, procedural, and antibiotic medicinal therapies. In medicines, we can basically go for the analgesics or muscle relaxants in case we require them. And if in case we find out some infection is there, then we can go for the antibiotics also, a course of antibiotics to reduce the infection over that area. In the supportive therapy, dental consultations, hygiene, maintenance, or the fluoride applications are the key points. Other than that, dietitians consult for proper diet maintenance of the patient, and the mouth opening, depending on the mouth opening, the proper diet should be given. Physiotherapy of the muscles of the oral cavity is very important. Along with that, the shoulder and neck exercises to loosen up the area over that side, and proper masticatory forces can be applied over that side. Counseling of the cancer patients is very important because they generally have low willpower after the surgical procedures or the radiations and all therapies. So counseling is also an important key factor, and speech and swallowing therapy is required for the supportive therapy to increase the mouth opening of the patient. In the procedural therapies, in the procedural patterns, they are very less used, but yes, they are used when the mouth opening is severely restricted. In those cases, we need to go for a nasogastric tube placement, or some ultrasound for inflammatory pain, physiotherapy, ultrasound guided physiotherapy for the inflammatory pain relief. These 3 are the basic modulation devices which we have turned up for the increased mouth opening of the patient. With time, the first one is that we used from way back with the ice cream sticks, increasing them step by step. Second is the histers, and the third one we generally use nowadays is the TrisCare. And we are going out for the studies also for using the TrisCare post-surgical, post-surgery, to increase the mouth opening of the patient. So all of the 3 problems are interlinked with each other, but have the same one or more the same treatment plans, like the maintenance of the good oral hygiene and good proper diet for the patient is the important thing to be maintained, so that they can have proper maintenance of the oral cavity. Thank you.
Thank you, Dr. Anshul.
Now we request Dr. Deepa to give
Deepa.
Thank you, Dr. Anshul, for highlighting the most common radiation-induced side effects when we are treating a head and neck cancer patients. So this is like mucositis is something which we face during radiotherapy treatment, and xerostomia happens afterwards, xerostomia and trismus. And mucositis is one of the commonest problem which can lead to treatment breaks during radiotherapy. Something which we have to remember is that apart from the radiotherapy, like IMRT facilities, which has shown some improvement in these side effects, it remains a problem even now when we are treating the patients. And so further research and more collaboration between the radiation oncologist and the dental surgeons are required in this situation. So that's what I want to highlight for this session. Thank you.
So much, ma'am. I think we've had fantastic 3 scientific sessions, and we've learned a lot from all the 3 sessions here. Now is the most, I thank all our faculty and the chairpersons for really making this absolutely amazing and spellbinding. Now we come to the most exciting part of the event, which is the quiz competition. This is the 3rd day for the quiz competition. So are you all excited? Are you all ready? If yes, just give a thumbs up using the Zoom emojis. So we are aware that yes, you're absolutely excited for the quiz competition. The pattern remains the same. Today is the 3rd day. The theme for the evening is intervention at the mass level. We have already finished the 2 quizzes on the theme of oral lesion, treating it right, oral prophylaxis care in oncology patients, and today is the 3rd one. There are exciting prizes. Let me just take the opportunity and excitement ahead to tell you about the prizes. All the participants who attempt for the quiz competition will get a certificate of participation from the organizing committee. For the winners, for the top 3, we have scholarship for the Certified Tobacco Cessation Specialist Program. The first, second, and third participant gets 50%, 40%, and 30% respectively scholarships for the advanced certification. The 4th to 20th position candidates get 25% scholarship. There is opportunity for selection for 100% scholarship for orientation course in tobacco cessation. Both the programs are accredited by Gujarat University. Our lucky winners every day are going to get Twist Care, as was also mentioned by our earlier speaker, for the mouth opening rehabilitation. These are the 3 certificate courses from ICanCaRe in collaboration with Gujarat University, the CTCS, Certified Tobacco Cessation Specialist, an 18.5 hours program. This is run over 8 weeks online and for 3 days in the offline mode. Numerous technology for data-driven intervention is taught in this program. The orientation course is an intermediate level certification and involves 4 weeks of intensive training with the experts, 2 days of offline training, and 4 weeks of online training with the experts. Tobacco Marshal, a program for all the people who are interested for tobacco control and tobacco cessation, and to really work towards making our community smoke-free and tobacco-free. To register, the website link is here right in front of you, ICanCaRe.in/academy. In case of assistance, you can always reach out to me or WhatsApp me on my number. Let's see, what is the quiz selection process? This is an online quiz. We have the link ready. Once the quiz master is online and announces to share the link, we're going to put it up on the chat box. Post that, the chat box will be disabled. You are supposed to only answer it online and not put anything on the chat box. There'll be 20 questions in the form of MCQs. Select the best answer. The fastest submitter with the maximum right answers on all the 3 days would be calculated towards the end of the program today. And we're going to have the winners at hand. These winners are going to be announced on 30th April during the valedictory session. Also, it will be available on the E-Conclave website and the ICanCaRe community page. All winners again will get scholarship opportunities to get scholarship for the certificate programs and also certificate of participation from us. It gives me immense pleasure now to introduce to you our quiz master for the evening, Dr. Harsh Dhar. He's consultant of head and neck and skull base surgeon from Medica Super Specialty Hospital and Cancer Center, Kolkata. He's an MS and MCH in head and neck oncosurgery, a visiting consultant at IPG MER Hospital, Kolkata, and also his special interest lies in thyroid and skull base surgery. So over to sir. Harsh, are you there with us?
I think he's not been able to join.
Okay, can I continue?
Yeah, please continue.
Okay, so these are the instructions for you, dear participants. We're going to share the link on the chat box. You need to open the given link, fill in your email, the first name, and your surname so that your records can be recorded by the system. Answer the questions. You will be given 10 minutes to start the timer as soon as the link is put down on the chat box. It will be in the form of MCQs. As I said earlier, you are supposed to choose the right answer. Once you are done, submit your quiz. After 10 minutes, we're going to close the response acceptance. And after 10 minutes are over, the form is going to take auto submission. I mean, you will not be able to answer further questions if you have missed out some questions. Okay. The decisions of the quiz master and the judges will be final and binding. All right. Here's the link for the quiz. Let me also put it down on the chat box for everyone's assistance. Sorry.
I have put it.
Yeah, thank you, sir. This is the link. I'm just waiting for a minute and then we start.
So you just have to click on the link and you will be directed to the Google page, and you will have to just go by each question, and the entire quiz will take, there are 20 questions and it will be only for 10 minutes and you have to submit immediately. The winners would be those who have already answered attended all the 3. So today is the last day for the quiz. So all the 3 quizzes you must have done. So once you are ready, just give us a thumbs up. The chat box would be disabled and everyone will be put on mute, right? So please just give a thumbs up or just put something, yes, we are ready, and we just start.
Okay, I'm starting the timer. It's 4:21 right now. We're going to close the link at 4:31 exactly. All right. Please ensure that you're filling all your details: email, phone number, name, institute, city, specialization. This is required to recognize you and also to print the proper name on the certificate. Okay. So here we go. Here comes the first question. Which of the following is true about malolabial flap? Are a very good option for alar defects, can only be superiorly based, can only be inferiorly based, have the best for match for skin at the dorsum of the nose, cannot be used as advancement flaps. Question 2. Which statement best describes reconstructive and rehabilitation goals in paranasal sinus cancers?
Yeah, Shruti, Dr. Harshadhar has joined.
Okay.
Yeah, I'm here, sir.
Yeah,
I can read the questions.
Yeah, sir, over
so
to
the
you.
option A, it's a very long question. So I think we'll give time for the candidates to go through this question particularly, because they'll have to go through each and every sentence. So first one is, although functional rehabilitation is important, following surgical removal of PNS tumors, aesthetic results take precedence. B, essential to obliterate matches and space following a total maxillectomy. C, often a stage free tissue procedure to separate the intracranial cavity from the iridocervical tract is preferred to primary closure with local flaps to allow recognition of postoperative complications in first 24 hours. And D, rehabilitation after surgical resection may be achieved with dental prosthesis or reconstructive flaps, such as the temporalis muscle without inclusion of cranial bone, or pedicled or microvascular free myocutaneous flaps and cutaneous flaps. Right. Question 3. Which should be the correct order of flaps as per the reconstruction ladder? Remember, in order of increasing complexity. So A, regional flap, microvascular flap, primary closure, secondary intention. B is like secondary intention first, primary closure, regional flap, and then microvascular flap. C, regional flap, secondary intention, primary closure, microvascular flap. And D, primary closure, microvascular flap, regional flap, and then secondary intention. So it's increasing order of complexity. Question 4, which one is not a transposition flap? So it is not a transposition flap. Rhombic flap, bilobe flap, node flap, dorsal nasal flap, or Z-plasty. Which one is not a transposition flap? Question 5, the blood supply to parascapular flap is dorsal scapular artery shared between parascapular flap and latissimus dorsi flap, is not distinct from serratus anterior flap, runs between the teres major and minor muscles, and E from the angular branch of coracodorsal artery. It's a bit tricky one. Hint is that it's regarding the course of the vasculature. Question 6, all the following are true regarding a free fibula osteogynous flap or mandibular defect, except a length of up to 20 to 25 centimeter can be harvested. Multiple osteotomies can be performed. There is minimal morbidity in terms of weight bearing and movement after harvesting of a free fibula graft. Adequate amount of soft tissue is available along with skin paddle for reconstruction. Question 7, which vein is not a reliable recipient for a free flap? Is in the head and neck. External jugular vein, internal jugular vein, facial vein, anterior jugular vein, and middle thyroid vein. Which vein is not reliable? Question 8 is, which is true regarding delta pectoral flap? The donor side can be primary closed, Preferred choice for pharyngeal reconstruction. Blood supplies from axillary artery should be raised as a musculocutaneous flap to preserve blood supply. E is distal end of the flap has the most robust blood supply. Which is true regarding the parietal island flap, that is the pedicle is from facial artery. B, blood supply from both sides must be preserved. Blood supplies from greater palatine artery. Blood supplies from lesser palatine artery. Or E, donor site has to be closed primarily. Question 10, which vessel is the most common choice for microvascular anastomosis in the neck? Superior thyroid artery, facial artery, lingual artery, transverse cervical artery, and occipital artery. I think this is a fairly simple question. Everybody should be able to answer. Question 11 is, which of the following are true about advancement flaps? Works better in areas in skin with less elasticity. B, have the greatest tension perpendicular to the proximal border of the flap. Not good option for cheek defects. Works well in dorsal nasal defects. E are good option for forehead defects. Question number 12, please look at the diagram that we have given, the shaded, the dark shaded area. What will be the classification of this defect as per the new James Long classification of mandibular defects? A is type 1, B type 3, C is 4B, and D is 4C. Question number 13, which flap is most ideal for reconstruction of large full thickness scalp defects? Anterolateral thigh flap, latissimus dorsi flap with skin graft, lower trapezius island flap, vertical rectus abdominis muscularis flap, or a parascapular flap. Blood supply to the temporoparietal facial flap. This is a tricky question. Internal maxillary artery, deep temporal artery, supraorbital artery, superficial temporal artery, or posterior auricular artery. Question number 15. All of the following are true regarding pectoralis major myocutaneous flap, except it is based on a branch of thoracoacromial artery. Transposition of the flap is limited by the arc of rotation of pedicle over clavicle. C, it can be used to reconstruct scalp defects. The most distal aspect of the skin pattern is the most poorly perfused. E, gravity may cause superior dehiscence of the flap. The following, number 16, the following are prerequisites for rehabilitation using an operator after maxillary defects, except defects should ideally not be more than category 2B as per modified James Brown. There should be a posterior shelf of soft palate as to minimize nasal regurgitation. The patient should have adequate mouth opening to enable measurement of defect and placement of prosthesis. The opposite upper annulus should be edentulous. Question 17. Full thickness defect of the upper lip not involving the philtrum and measuring less than 1/4 of the lip width should be closed with a perielar crescentic flap, with a perielar crescentic flap combined with an Abbey flap, with an S-Lander flap, with a Karapanzik flap, or E primary closure can be done. The hint is less than 1/4. So question number 18, which of the following is an important contraindication for performing a submental flap? Size of defect should be less than 5 cm in largest diameter. There should be a good arc of rotation from donor side to defect. The venous drainage of the flap should be into the internal jugular system. Presence of clinico-radiologically positive nodes at level 1A. So which is an important contraindication. Right. Question 19. Free flap reconstruction for head neck cancer surgery is contraindicated in diabetes mellitus, sickle cell disease, systemic lupus erythematosus, or a peripheral vascular disease. Question number 20. The purpose of a guide bite or guide pin prosthesis for mandibular rehabilitation is to improve mouth opening, bear implants for dentition, prevent deviation of the remnant mandible after flap reconstruction, and improve occlusion. D, improve speech. Compulsory question 1 is, would you practice oral screening tobacco counseling in your routine after this workshop? So click on the options that are given. Yes, no. I want to start a ICanCaRe tobacco wellness and oral screening center, and I want to get trained in tobacco intervention. These are your options. So compulsory question 2, TrisCare, the innovative mouth opening device with TrisCare made of foam material, which is unbreakable. If sturdy mouth opening can measure the grading and improvement of mouth opening, you would like to order the same for your patient. So you can tick on the link. Number 3, Certified Tobacco Cessation Specialist course is the only comprehensive tobacco course accredited by the Gujarat University. So please tick, I think, on both can be the options. Right. I think with that, we will be ending the quiz.
Yeah, thank you so much, sir. I think we just have 1 more minute left for the portal
Yeah.
to be closed for accepting the answers.
So can the candidates go back to the questions, or it's
So
already
I mean,
done?
it's available on Google Form, so they can
Yeah,
always view the questions available.
Right. Okay.
As a reminder to all our participants, it is compulsory to participate in all the 3 quiz to get the top 20 prizes for you. Otherwise, you'll always have the opportunity to win scholarship to the certificate programs, the intermediate level orientation course and tobacco cessation program, as well as the certificate of participation from the organizing committee. These are the prizes. One more time, I would like to bring to your notice that you get scholarships for the programs, the Certified Tobacco Cessation Specialist program, and the opportunity to win TrisCare as well. This is the mouth opening device, TrisCare. I think quiz time is now over. With sir, your permission, we would like to close the portal. First, sir.
Yeah, sure. Absolutely.
Okay, sir. Thank you so much. I think we end the quiz here. Day 3 quiz is now over. Yeah, so you were saying something. Sorry.
No. All done.
Okay, thank you so much, sir. So this is TrisCare, the indigenous mouth opening device, which has been designed by ICanCaRe for easy rehabilitation of the jaw for the patients. And the best part is it has a screw, so the pressure is elevated. It's very sturdy, very pocket friendly, can be carried easily anytime, anywhere, and can be used in a very simple protocol so that the mouth opening can be increased over a period of time very successfully. We have seen that this has given beautiful results and has been also endorsed by numerous of our oncosurgeons across the country very successfully. In case you would like to have this for your patients or for yourself, it is available on icancare.org/TrisCare. I'm going to share the link also on the website. Let me quickly share a short video about the product so that you know about its indigenous nature. And you also get to know about the type of product it is. That was the device, again, TrisCare mouth opening device given by ICanCaRe research research in collaboration with Gujarat University. I think it's now time that we move towards the next section of our program today, towards the panel discussion. The major focus of the panel discussion today is establishing a protocol for oncology setup and ensuring quality of life in cancer patients. For this, our moderator for the evening is our own dear Dr. Manoj Tyal, sir, the Director of Radiation Oncology at Max Super Specialty Hospital, Parpadganj, New Delhi. For our panel discussion chairperson, we have Dr. Somnath Roy. Sir is currently consultant medical oncologist at Tata Medical Center, Kolkata. He has special interests in breast, gynecology, lung, and head and neck cancer. He is a member of ASCO, ESMO, and ISMPO. He has been awarded with numerous felicitations, including the European Certification in Medical Oncology, MRCP UK Partner in 2016. We also have esteemed panelist, a very terrific panelist here on board for discussion, Dr. Anil Thakwani, the Director and Senior Radiation Oncologist from Sharda Hospital, Dr. Sanjay Lab, Fellow of Royal College of Surgeons, Edinburgh, UK, Dr. Deepa Gupta, Senior Consultant from Medanta. Sorry. Dr. Manisha Lakhanpal Sharma, Professor and Head from Department of Oral Medicine and Radiology, IKS Dental College. Dr. Rajesh Jain, Head and Senior Consultant Surgical Oncology from Action Cancer Hospital. Dr. Kajal Pandya, Clinical Nutritionist and Dietitian from NutriCare, Your Diet, Your Health, and ex-Chief Dietitian from Apollo and Medanta. Dr. Tarun Mittal, Dentist, prosthodontist, and a private practitioner from New Delhi, Ultima Dental Implant Center. We also have Dr. Sudha Shah joining us as speaker from the second session, and also Dr. Deepa Joseph, professor from AIIMS. I now hand over the dais to all our esteemed panelists, chairperson and moderator, Dr. Manoj Tyal. Over to you. Thank you.
Thank you, Shruti. So, we already had a very good presentations from Dr. Sudasa and my other colleagues. And when we talk about management of complications related to cancer care for oral cavity and other structures related to swallowing and xerostomia, it's quite important that we should be on a same platform. And if you can, because whatever we do in our country, our people may behave a little different as compared to the Western people. So I think it's better that we discuss these scenario in our own clinical practice, and we can devise a protocol, because management of these complications is very important for the quality of life in our patients. So my esteemed panelists have already been introduced by Shruti, and Dr. Somnath Roy is our chairperson. So when we talk about oral cavity, it is highly susceptible to direct and indirect toxicity, toxic effects of cancer, chemotherapy, and radiation. The most common complications, as we have already seen, are mucositis infection, salivary gland dysfunction, taste dysfunction. The secondary complications related to these are dehydration, dysgeusia, and malnutrition. There are many others also, but we will be focusing some more on these. And severe oral toxicities can compromise delivery of optimal cancer therapy and directly affect patient survivorship. So incidence or prevalence of these side effects has been well reported. So let's not get into too much of detail into that. And this is the pictorial representation of methods of cancer therapy and oral health consideration, whether it is a local therapy with surgery or radiation, and systemic therapy in the form of chemotherapies, hematopoietic stem cell transplant, targeted therapies, immunotherapy, and the bone-directed therapies. So the management of oral complications of cancer therapy include the identification of high-risk population, patient education, initiation of pre-treatment interventions, and timely management of lesions, and assessment of oral status and stabilization of oral disease before cancer therapy are critical to overall patient care. So it is essential that a multidisciplinary approach be used for the management of cancer patient before, during, and after cancer treatment. So that's where we are, and that's where we need to be on the platform to discuss and devise a protocol. So my questions are very generic, and I'll ask Dr. Manisha. So what is the etiopathogenesis of oral complications of these therapies? So can you put some light on this, Dr. Manisha?
So thank you for inviting me, sir. Thank you, Dr. Pavan and his team, especially. So etiopathogenesis is very clear. It has been enumerated that initiation, then upgradation and accelerated acceleration, and then inflammation and ulceration is the mainstay wherein the complication starts to happen. And post that, what adds to it is the xerostomia which happens, the fungal component which takes part in the whole, the fungal component which predominates. So finally, everything comes together. We have oral mucositis, we have xerostomia, and we have fungal infections to start with.
You rightly said it's a very complex interaction among multiple factors. So there are lethal damage to the tissues, and the attenuation of immune system. There is interference with normal healing. And if we can put it, more pictorially, we can see that there is initial phase, epithelial phase, ulcerative phase. And there are some indirect toxicities which are caused by non-oral causes like myelosuppression, lot of tissue-based immune cells and loss of tissue-based immune cells, and loss of protective salivary continuity. So you have directly put it. So how to reduce frequency and severity of oral complication in this context, Dr. Manisha?
So, sir, it has been really interesting to listen to Dr. Sudha and Dr. Anshul, especially speaking about handling of the oral complications. There's something that has to be taken care of before the patient undergoes a treatment. Like Dr. Sudha said, one OPG needs to be done as the screening radiograph, and anything which needs pre-treatment protocol has to be set, and anything which needs treatment then, like extraction of the mobile teeth, some cavities which need to be filled, fluoride applications, and one thing which has to be done is coronoplasty. Why coronoplasty? Because when this operatory procedure is done, there's shrinking. And when there is shrinking, inevitably the sharp cusps, they go and they impinge onto the buccal mucosas, which cause further injury. So this was one point I wanted to embark on, number one. And there are a lot of things which they have already suggested as to how to handle oral complications. But if you give me 2 minutes, I'd like to add to it. Should I?
Go ahead.
So, sir, there's some concept of ionic brushes which has come into market. It is still under development. In Japan, it is being used, but I think you can go through the scientific data, how ionic brushes are being used. Second thing is water picks are there in the market. Other than the dental flosses, which was enumerated by various speakers, the water pick is a very important thing which can be used. TrisCare we have been using. We have very, very good results with TrisCare, and physiotherapeutic ultrasound really helps. Other than whatever they have spoken, physiotherapeutic ultrasound along with LLLT, which is lower level laser therapy for trismus, also helps. And for salivary gland, for xerostomia, wherein fibrosis of the salivary gland has not taken place, ultrasound is also an effective treatment modality to add to whatever they have suggested so far. Thank you.
So, you are rightly putting all, and, we should be having a comprehensive oral hygiene protocols in place. And there should be, attention given to, factors that may compromise the integrity of oral mucosa. So it's very important, we should have some knowledge of, we should have the etiopathogenic knowledge of, these complications, and we should try to make our protocols based upon this knowledge, and how to prevent at each step if something can be done. Yeah, so if I come to the surgical aspect of management of these complications, so Dr. Rajesh, what are the pre-operative measures to reduce the morbidities?
There are probabilities of big surgeries of oral cavity as we are doing commandos. Like difficulty in speaking after surgery, difficulty in swallowing after surgery, cosmetic problems, and especially when radiation is added to it, then all the complications which the previous speaker has told, they are all added. Now, as a surgeon, it's my duty to prepare the patient and assess the patient in such a way that we minimize the post-operative complications. For oral surgery, for oral cancer, the most important part, the role of dentist. Because when they have plaques in the oral for the teeth, when there's infection in the gums, because most of the patients take tobacco, so they have infections, they have bad gums. So we must show every patient to the dentist first. Oral prophylaxis should be done. If there is the necessary mechanical cleansing to be done, if there is any unsalvageability or anything which increases chance of infectious complications should be removed. Because I have seen that when the patient has infected or bad oral cavity, the chances of post-operative infection as well as chances even up to pneumonia is very high. So that is one. And second, my planning of the treatment is very important to decrease morbidity. Suppose I want to plan a surgery which needs some sort of reconstruction. Then I have to plan my reconstruction in such a way that I do minimum tissue injury, keeping oncological principles in mind. If my margins are adequate, then I should sacrifice minimum tissue. Number one. And number two, the type of reconstruction which I do. If I say use a flap which is very bulky, that will reduce the volume of oral cavity. So the space in the oral cavity will reduce. There will be difficulty in swallowing in the oral phase as well as in the pharyngeal phase. So if I say, for example, if there is a defect which I can do by a free flap, like a flap, free radial forearm flap, that will give a thinner flap which gives more space in the oral cavity and good cosmetic as well. So my choice of reconstruction is very important. If I'm removing a mandible, for example, segment of a mandible or a part or a one hemimandible if I have to do, so I must see that if possible, I put fibular graft in that, so that the cosmetically it is better, the movement is better, the swallowing is better. So my pre-op prophylaxis from the dental point of view, my planning of reconstruction, my surgical planning keeping in oncological principles should be absolutely fine so that we can decrease the complications. And most important part is teaching, teaching and teaching. I must sit and counsel the patient because there are psychological issues associated with these surgeries. So my patients should be counseled, should be taught that these are the problems which you are going to encounter. So I must explain the various exercises, shoulder exercises, oral exercises, mouth opening exercises, speech therapy, which he has to do before surgery as well as after surgery. And I must sit with the wife and other relatives to the patient and explain everything. It has been seen over the years, like last 26 years I am doing practice. When I sit pre-operatively with the patient family, counsel them about the complication, about the morbidity, that will reduce actually the morbidity. So psychological counseling, dental treatment, pre-operative surgical planning, and to give adequate nutrition support pre-operatively and post-operatively. These are the basic things which I'll plan as a surgeon when I go for a big oral surgery.
Yeah, you are just rightly put in, so many important aspects of, cancer care, because when the patient, oral cancer patient or a head and neck cancer patient, starts his journey for his treatment, he always has to pass through the surgeon's door also. And, to initiate, to prevent future complications or just to reduce the complication happening in future, because it's not only the treatment which is going to cause the trouble, because it is post-treatment effects also. We need to look after those effects before we have to do a proper planning. So Dr. Rajesh has rightly, put up all these, important points in one place. So, when we talk about when post-treatment, post-surgical treatment, when we talk about adjuvant treatment with the radiation or chemotherapy or chemoradiation, and obviously, Dr. Sudha, you have talked about, it's not only radiation which is causing mucositis in cancer patient, it is other therapies also. So can you, highlight the facts about the management of oral mucositis in, otherwise, other than radiation in regards to stem cell transplant or chemotherapy also? Yeah.
Hello.
Yeah.
Yes, sir. So can you hear me?
Yes, we can hear you.
Yes, sir. Yes, sir. So when the patients are undergoing bone marrow transplant, the mucositis, it is not very high grade nowadays. The mucositis, first what we do always before going for bone marrow transplant, the patient will be visiting to our department and will be taking a OPG and doing the prophylaxis and advising the patient how to take the oral hygiene, how to maintain the oral hygiene. There will be a phase when the mucositis grade will be more. That time, just giving ice cubes. It is 2 years we have done bone marrow transplant in our hospital, and till date we are able to handle it very nicely without any medications. There are patients who have completed just 3 months and 6 months, and the mucositis is not there in the it is gone. So just maintaining the oral hygiene has worked very nicely. And then patients are undergoing all the dental treatments. So I feel that oral hygiene play an important role. So symptomatically to treat the teeth, what is required, just to, if the tooth is impacted, not to go for extraction, not to go for disimpaction, nothing. Just to guide the patient how to clean it, how to maintain the oral hygiene. Because the patient has come for the cancer treatment. So it is the phase, they have to finish the treatment. So for that, they really take care and they follow it. And after 1 year, they are out of the risk. So we are able to do the proper dental treatment. But there are many who are undergoing root canals and all, but no extractions. We are just trying to avoid. So mucositis and all, it is just a time when the patient is on bone marrow transplant.
Yeah, so these are the few points here. And how about any preventive therapies? Can you put some highlight on palifermin or maybe cryotherapies in management of mucositis?
So here we have not found any evidence, just oral hygiene and cryotherapy. Sir. It works good, not giving any of the medications. Have our hemato-oncologists, they are very much careful about it. So they just go very slow, no medicine, nothing. And I have found always weekly once I have to go for 21 days, the patient will be admitted post BMT and BMT. I'll go and I'll see that patients are maintaining. So cryotherapy works very good. And there will be saliva replacement mouthwashes, which they use. No alcohol-based mouthwashes. The diet, as you tell, is very important. The diet, they are given overcooked diet, which has to be taken care. So that is the main things.
You would like to add something in management of mucositis during radiation?
During radiation, sir, we have started the photobiomodulation, but still it's going on, not yet proved how effective it is. Only worried for xerostomia, which is a late complication, which the patient will come and tell that I am disease-free. Now, why I'm not able to eat? So want to work more on xerostomia. Mucositis, it is there, but it will be a phase which will go as IMRT and all. So nothing much, sir.
Okay. And would you like to give some emphasis on if there are some specific recommendations which you generally do not advise, but they are commonly patients come with some information about. So do you have some points in saying that?
Sir, I couldn't get you, sir. Specific recommendations.
So some points, some of the therapies which are the patient might come to you and he tells you that if you give advice in regards to GCSF gargles or something like that. So do you have something in to comment upon that?
Yes, sir. We will be explaining the patient about all the things, but we'll tell that when it is required, we'll be doing it. Just have patience, finish just positivity, and the patient do well, sir. Just to tell them. And then water pick, as madam told, it really works good. The water pick, which has got a button with a regulator. So with the regulator, if the patient is able to use that, they keep the mouth clean. So for all the things which they have, we'll be answering it. We'll tell that when, as and when required, we'll do it. And without that only, it works good, sir. If we pre-op, if we see, and then take over the thing. Because patient once, when they come for the first time to us, they'll be like, why dental? why dental? So that time takes time, but afterwards, just explain the patient and then they'll be okay about it.
Deepak, what is your perspective in management of complications, oral complications during radiation therapy?
So, as a radiation oncologist, it is important to understand what site you are treating, because other than oral care, which we have already discussed by many of our panelists and also with the earlier lectures, that we need oral care, we need dental care. But other than this, the important as a radiation oncologist is important what we are treating and how much dose you are giving and how much chances that the critical structure is going to be received and how you can optimize the dosage. Because what I think that is one of the most important factor is to prevent the toxicity. With the even best of the technology, other than protons, we are able to reduce the doses, but still there is a significant part of the normal tissue which we receive the doses. So that is which I think is one of the most important, other than oral care, which is already been discussed. Dental care, pre-dental prophylaxis is important, because if the patient has loose tooth or broken tooth or there is a caries, this tooth has to be removed before the start of treatment, because we know these are going to create complication post-treatment, and it is increase the complication if we need dental extraction, especially post-treatment.
Yeah. So, and how about dental prophylaxis? How important, as you have already said. So, and so when do you take a decision for extraction?
So what we do is it is important that each and every patient of head and neck cancer should undergo a dental assessment by a specialist dentist, and if the patient found to have any bad tooth, caries tooth, or there is a broken tooth or stump, these needs extraction. We advise to do an extraction before we start the treatment, because it is important if these can be handled pre-treatment, because post-treatment these are going to get complication, especially if the extraction is required, especially if that area is going to receive a high doses which is close to 60 or 70 grade, then there is a high chance of osteoradionecrosis. So if the patient needs dental extraction, he should undergo extraction.
To starting radiation treatment.
Yeah, before the start of treatment.
Yeah. And if extraction is not possible, so what next best measure to be taken? I'll ask this question from Dr. Manisha. So suppose extraction is not possible, how to manage this patient? Yeah.
It depends.
Yeah.
Can you hear me?
Yeah, we can hear you.
So it depends on what stage are we talking about, what stage of the tooth we are talking about, because I think, as Sir said, Dr. Deepak said, extraction is a must. If it needs to be done, it needs to be done. We just had a patient who had undergone radiotherapy, and because the 8, which Dr. Sudha was saying that sometimes we have to take a call whether to remove or it's not possible. Now the third molar, it could have been extracted before, but right now, because of post-extraction fibrosis, it cannot be removed because there's so much of fibrosis, the patient doesn't have a mouth opening. So if it has to be removed, it needs to be removed, you have to remove it. Just in case extractions cannot be done, then we go for something called, we can just do a pulpotomy or a pulpectomy for the patient and just restore the tooth and keep it there, so that there is no ingression, further ingression which happens.
Okay. Dr. Tarun, you want to add something more?
Ma'am rightly said, we can do pulpotomies in the same way. We can just remove the pulp of the tooth, and suppose if we cannot extract the tooth post radiation, so we can do it as a temporary treatment. We can do just pulpectomy, and we can keep the tooth open so that nothing builds up inside. And if we can complete the root canal treatment in that case, we should we can also complete the root canal treatment and leave the tooth like that.
Okay. So, Dr. Arun, how about management of oral infection during cancer therapy? Yeah, please.
So basically, sir, oral infection can be, always prevention is better than cure. So oral infection, we should not, try to not the oral infection happen in the mouth while oral cancer therapy is being given. So for that, mouthwashes are of great help. we should advise patient for sodium bicarbonate mouthwashes, which reduces the pH and effectively reduce the oral infection. And the chlorhexidine mouthwash is very helpful in that case. So, but if there is a, we have to treat an infection, then of course we have multiple antibacterials, antibiotics, antiviral drugs, antifungal drugs available for us. So all those drugs can obviously help us for the cancer, this oral infection therapy.
But I want to say this, Dr. Manoj,
Yeah.
the chlorhexidine mouthwash is still, we don't find much of the evidence to decrease the, incidence of mucositis and everything. But the available data, which is recently published by multinational association of cancer prevention, is this benzidamine mouthwash has been recommended by majority, and it has been found to have better outcome. What is your take on, Dr. Tarun, to use benzidamine based mouthwash rather than chlorhexidine based?
Basically, benzodiazepine mouthwash is having more of the role in anti-inflammatory, but antibacterial role is a little less for benzodiazepine. It is basically more helpful in mucositis and anti-inflammatory.
Yeah, so benzidamine is a good, local analgesic, and it has an analgesic effect. And in regards to prevention of infection, chlorhexidine also has a role, but chlorhexidine is actually quite irritant to the mucosa, and sometimes it causes a little more pain when we want to give relief from pain. But yes, as an antiseptic agent for prevention of infection in mucositis, if it is not radiation, if it is chemotherapy-induced mucositis, or if it is generally any other infection in the oral cavity, suppose the patient has a pre-existing tonsillitis or something. So this might help. And Dr. Sudha, how about management of fungal infection, oral fungal infection in oral care, the role of antifungals and any other therapies, and what is the pathophysiology of fungal infection in these patients?
If the patient is not able to maintain the oral hygiene or radiation therapy, so the chances of oral function is fungal infection is too high. So here we give candid mouth paint and 4-can tablet to be used as a mouthwash. We give the 4-can tablet to be 150 mg or to be put in 1 glass of water and rinse it 3 times a day. So that I have seen it has worked very nicely instead of giving tablets to take. So that has candid mouth paint and 4-can tablets as a mouthwash works good for fungal infections.
So, fungal infection is quite common in, management of oral cavity complications, because when it is radiation-induced xerostomia will be there. So, and that also will be affecting it. Then, other common cells, when they are getting washed off, by oral antibiotics or something, then again, the patient is at a higher risk of developing, these fungal infection. And, Candida is generally a common cell in our oral cavity, but our patients, the cancer patients, are immunocompromised. So these patients do get, candidiasis more commonly as compared to, the immunocompetent host. So, if Dr. Tarun, can you put some highlight on, the viral infection in oral cavity, for as a measure for quality of life issue in our patients?
The HPV is one of the common virus which affects oral cavity. So, of course, the quality of life, it affects quality of life of the patient, because most common being mucositis patient face. So in that case, antiviral drugs like acyclovir and other antiviral drugs are helpful in that case.
Yeah, so it becomes very important to identify, the infection in the oral cavity, because herpes is one of the common, reasons behind so much of oral pain in our patients. So we should be looking for that as well, rather than attributing everything to treatment-induced mucositis or maybe fungal infection or bacterial infection. So we should be aware of herpes or non-herpes viral infections as well. So I'll ask this question from Dr. Deepak because Dr. Anil could not be present today. So what are the various preventive strategies to decrease the swallowing disorders, Dr. Deepak?
So in terms of swelling, now we understand over a period of time there are swelling structure which is important. If we can spare with the radiation, we can decrease the swelling, and it has been seen in a randomized trial which has been recently published by Christopher Nutting. If you reduce the dose to the constrictor mean dose to a less than 50 gray, that will help actually to improve the swelling, because if you improve the swelling, and there is a approximately 10% of the aspiration risk if you don't spare the swelling structure. So sparing this swelling structure with a advanced technique of radiation is possible, and this actually help to decrease the swelling, improve the swelling function over the period of time. And this is one other, this is known as dysphagia optimized IMRT, and that's it.
So these are the preventive strategies. For the surgeons, it is very important, as Dr. Rajesh has already pointed out earlier, that the resection should be optimal, and IMRT or any other radiation technique which can reduce the dose to these constrictors might help, and range of motions and resistance exercise. So the speech therapist and the swallowing speech therapist, they also have a very important role. And there are different rehabilitation strategies like different exercises and modifying the bolus volume, and the food consistency also help in decreasing the swallowing disorders. So Dr. Arun, how do you manage the dental caries in post radiation therapy patients?
In post-radiation therapy, first of all, bicarbonate, sodium bicarbonate mouthwash is a great preventive tool for the cavities, to reduce the incidence of cavities or dental caries. And apart from that, as a preventive therapy, patient can be done with the varnish like titanium tetrafluoride varnish, which is a newer one. Earlier, we used to use only 1% sodium fluoride varnish, but nowadays, like titanium tetrafluoride and silver diamine fluoride varnishes can be used, which have a considerable good amount of fluoride and fluoride releasing capacity, so the dental caries are minimized with that. Apart from that, if we have to do restoration in the patient mouth, so nowadays composite restoration is the good option, and the next generation composite restorations are composite restorations which have fluoride in it. So those are basic polyacid modified composite resins which have inbuilt fluoride releasing capacity in that, and which while treating the patient for the dental cavity, those restorations are also providing the prevention for the other cavities to happen inside the mouth. Apart from that, chlorhexidine mouthwash is, if patient is tolerant for that, like because it induces mucositis. If mucositis is not very much there, chlorhexidine mouthwash can also be given. And brushing, we should always ask the patient to do brushing, maintain oral hygiene and brushing at least 2 to 3 times a day. And apart from that, dietary modifications are much required. And liquid diet should be given to the patient. And for xerostomia, because post therapy, there are chances of xerostomia are there. So in that case, artificial salivary substitutes should be given to the patient, so which effectively reduces the incidence of cavities in the mouth, dental caries in the mouth.
Yeah, and Dr. Rajesh, How about management of trismus? So, we know these, but what are the surgical aspects of management of trismus?
See, the trismus we can find in patients who are tobacco tumors as oral submucous fibrosis. Trismus we find in patients who have undergone surgery because of the resection of muscles. Trismus we find in patients who undergone radiation because of post-radiation fibrosis. Trismus we find in situations where patient has undergone multimodal treatment. Now, depending on why there is trismus, there are various strategies. But to begin with, we start with exercises, mouth, jaw stretching exercises. We can have this unassisted mouth exercises, like opening the mouth, then lateral jaw exercises, right, left. And then if the patient is instructed properly and do the jaw exercises, it helps. Second, if that doesn't help, then we do assisted jaw exercises, like putting some ice cream sticks as it is shown on the screen, staged tongue depressors that we put. If that also doesn't work, then we go for therabite, like as you are showing this ICanCaRe. So these are very, very important and very scientific tools to manage trismus, because we can measure the amount of trismus, we can measure the relaxation after the intervention, and at the same time, low cost, these equipments are very low cost, everybody can buy. And then finally, if the trismus is so problematic and it doesn't like response to these conservative measures, then there are surgical approaches for the trismus. While doing cancer surgery, when we remove the tumor, sometimes we make the contralateral side free to decrease the trismus. Sometimes in a non-cancer patient presenting with submucous fibrosis, we do surgical intervention like releasing of the stretched fibers and do reconstruction with nasolabial flaps and flaps so that we can cover that defect. So sometimes we have to release the coronoid process from the joint to release the trismus. So there are surgical procedures, there are conservative procedures are there. But I think the most accepted and the most useful measures in all the circumstances is use of these small devices like therabite. And if the patients are taught properly and if they use it religiously, then they really help well. This is basics how we treat it.
Yeah. So I think hearing from the surgeon's mouth, this is very important. Prevention or the management without surgery should be our first option rather than waiting for the surgeries to correct this problem. So it's very important that trismus is being looked after even prior to initiating the treatment. The surgeon is aware of prior to surgery that what are the chances of this patient is having trismus, or if anything needs to be done during the time of surgery. And during the course of adjuvant treatment, when it is radiation treatment. So even during the radiation treatment also, the patient needs to be, doing all these mouth stretching exercises rather than, waiting this trismus to happen and then start applying these appliances. So it's very important because prevention here is better than cure, I think, whatever we hear from a very long time. Dr. Kajal, what are the nutritional consideration in patient receiving therapy for cancer? So, this is a very generic question, but it's quite pertinent to ask this question from you because you have a very good experience in managing nutrition in cancer patients. So, if you can elaborate further.
Yes, sir. Yes, sir. Thank you very much. Can you hear me, sir?
Yeah, we can hear you.
Okay, fine. So the nutritional considerations for patients receiving therapy, cancer therapy, first of all, I would like to see is, do you assess the patients before you start any kind of a therapy? And especially if you're talking about head and neck cancer therapies, we already know that these patients, because of reduced food intake, because of the disease condition, they are already undernourished, or rather I would even say malnourished. So the nutritional status definitely becomes of prime importance, especially to survive the therapy or to take the load of the therapy and the therapy to give results or to work much better. So I would say Pre-therapy, that is very important to understand the patient's nutritional status, and during the therapy also see to it that the nutritional status is improved or at least maintained during the therapy, because we know that there is going to be so much of side effects of the therapy which will not allow the patient to eat better, etc. So the nutritional considerations are, first of all, is to give them nutrition dense food. Now the nutrition dense food means giving enough amount of protein, giving enough amount of carbohydrates, fat, etc., so that their nutrition recommendations are met. Nutrition recommendations will definitely be individualistic depending upon from patient to patient, but yes, we need to focus is mainly on the proteins, the carbohydrates, the fat, so that the nutritional status is maintained. Secondly, the nutrition status will help to to withstand the side effects of the therapy. And as we have already seen in the discussions, that the side effects are such great that patient is unable to eat, unable to chew, unable to swallow. A normal person not allowed to do this would not eat anything, right? But a patient who's suffering from it and we need to feed the patient, it becomes a very difficult task for that. And the recommendations are also huge. If we talk about protein, for example, it goes up to approximately 100 to 120 grams of protein, and that's quite a lot of food. If you see, it's not a small pill that the patient has to just take in. So yes, we need to feed these patients. It is going to be a difficult task to feed these patients, but by hook or crook we have to feed them. So it could be a liquid, a nutrition dense liquid diet, soft diet, semi-liquid, blended, whichever way we can make the diet much more nutritious, more palatable for the patient to eat, especially to swallow, or even keeping in mind the blandness, so that there is no pain, there is no spiciness, it's cold food, so that it does not hurt the patient while eating. And secondly, it could be even at a worst come worst scenario, we may even have to give as a tube feeding also. Now, secondly, even if we are not able to provide enough amount of nutrition from the food, that is whatever kitchen food I would talk about, maybe some nutritional supplements also can be added for a short period of time till the patient starts eating very well. That is very important. And thirdly, I would like to even mention here is keeping the patient's food preferences, choice, dietary habits, the traditional background, all that is very important for us to understand, because then only he or she will comply with the food. If a normal human being, for example, I would just talk about dal and chawal and blended together and made into a paste and given, it's not very appealing. And especially a patient who's suffering, whose morals are already low, not feeling very good, not feeling good, it's very difficult to feed. So the way we can make the food much better, much more denser, better looking, easy for them to swallow is very important, and where they can relate to that food, that is most important. Because I have seen that when they can relate to that food, the compliance is much better, kind of like you talk about something which is out of not available also in the country or in the place, and you still advise as a dietitian, that doesn't work. So keeping all that in mind, nutrition becomes, I feel, even if we talk about all the medications and dental visits and doctor visits and all that, but if the patient is not in the condition, not nutritionally fit, will not visit anybody, will just sit and stay at home, kind of, and none of us can do anything. So to make them get up straight, go to the hospital, go to all kinds of care, the patient needs to be nutritionally fit, and feed as much as we can to these patients. And recommendations, we already know there are a number of guidelines what we need to know, but yes, it would be still very individualistic for each patient. This is what I would like to talk about nutritional considerations for patient receiving the therapy.
Kajal, you rightly put it, for head and neck cancer patients or any patient who requires a lot of nutrition, there are a lot of challenges, especially when there is mucositis, when there is dysgeusia, the patient is not able to smell the food. They have their own limitations. They want to have particular kind of food. Some are vegetarian, some do not like non-vegetarian food. So even traditions and culture, that also make a lot of dictation in nutrition. So this is very important. So whenever we want to devise a protocol in a management of oral cancer patients, so these points are very important. And Dr. Deepak, how about how about parental nutrition versus enteral nutrition? When do you want to put a tube, or you want to avoid a tube at all the cost, and what are the ways you can avoid the tube?
So the most important part, as Dr. Kajal has discussed, that nutrition is one of the most important, especially during the course of radiation, and especially for the head neck cancer. Nutrition is the one part which help us in completing the treatment and with optimal outcome. Because if the patient don't take food, there is a chances that he need admission, he need parenteral nutrition. The best way is to put a rice tube. If the patient is not able to take enough calories per day, which is required, the most important thing is to put a rice tube, give the continue to feed with the mouth whatever he can take, and if it is not able to take, then the rest of the feed can be given with a rice tube. And if the patient is not willing for the rice tube, then the another important way is to put a PEG tube or a parenteral nutrition, maybe IV fluid or IV support, that will help to give the adequate amount of calories. Because this is one of the important part in the management, especially during the course of radiation, to complete the treatment without having a gap. Because if the patient don't take, you have to give breaks, and break does not result in a good outcome during the course of treatment. So first, to try to encourage the patient, give the counseling, give the adequate diet orally. If not possible, then put a rice tube. If not willing for rice tube, then another option is to give the IV fluid or IV parenteral nutrition to maintain the adequate calories, so that adequate weight can be maintained during the course of treatment.
Right. So, Dr. Sudha, can you put some light on management of dentures and orthodontic appliances in patients receiving cancer therapy? Because this is a tough question, especially for oncologists, when the patients have dentures or they have orthodontic appliances. So can you guide us in this? Dr. Sudha, are you there? Can Dr. Manisha put a... No, okay, Dr. Sudha is there.
Yes.
Yeah, Dr. Sudha.
Yes, sir. Yes, sir. The dentures, the patient, when they are wearing a denture, and if the patient is going for radiation therapy, they are asked not to use the denture at least for 3 months. After 3 months also, the denture care has to be given to the patient, how to handle it, how to use it. After 3 months also, when they put, there is mucositis, there is xerostomia, but they will be needing it for taking food. So they have to use partially. So for one year, the use of dentures and prostheses are not advised if the patient is on radiation therapy, if for head and neck cancer patient. And if the patient is having orthodontic appliance, the orthodontic appliance also is not advised for the head and neck cancer patient if they are undergoing radiation therapy. There will be more radiation after effects which happens if the patient is with orthodontic appliances. If the patient is taking bisphosphonate or any of the medication related necrosis, any medicine, that time also, if they are using the denture, they should be aware that denture can prick. If it is pricking or any problem is there, immediately they need to see a dentist who can make changes, and then they have to put it when it heals. Mostly it takes 1 month to heal and then to use it. So we have to be careful about that. So for 1 year, for the radiation patient, radiotherapy patient, for head and neck cancer patient, and for bisphosphonate or medication related lifelong, they have to be careful with the dentures.
Manisha, what is your take on with the dentures and orthodontic appliances?
I think it has been rightly put by Dr. Sujata here. The guidelines remain the same, and when they start using it, sir, they have to get the dentures well fitted, relined. Only then they can start using it, because there are a lot of changes which have taken place. So a new denture, number one, And relining has to be done. So they have to be constant with their prosthodontist. Number two, when they're putting their dentures at night, it has to be in an antifungal solution. So that is very important, which needs to be done. So, and general cleanliness of the dentures, another important thing. The obturators that they are using, the clasp should not hurt them, because there are a lot of them who come with a sharp clasp here and there, which is hurting. So it has to be taken care of. So that is the major guideline which has to be followed.
Yeah. So now we come to, if we have to conclude, assessment of oral status and stabilization of oral disease before, during, and after cancer therapy are critical to overall quality of life for our patients. And future research is needed to reduce incidence and severity of oral mucositis, improve infection management, protect salivary gland function, and minimize risk of chronic sequelae. So here we end this panel discussion, and I invite Dr. Roy to give the concluding remarks. And I thank all my panelists to actively participate in this. Dr. Roy, please.
Yeah, thank you for the nice discussion in the panel discussion. From the medical oncology portions, I just want to mention 2 to 3 things. Because when the mucositis is increased when the patient is concurrent chemoradiations, and sometimes there is some targeted therapy like cetuximab on these kind of things, the mucositis there is an attributing factor of oral mucositis, not only oral mucositis, but also GI mucositis. And there is sometimes when in dealing with a head and neck cancer with a neoadjuvant chemotherapy, the triplet regimen with taxane, platinum, or 5-FU based, there is also some mucositis occurs. So these point of things should be kept in mind, because adding chemotherapy or any targeted agent with a use attributable risk of mucositis. Number 1. Number 2 is there is the guidelines. If we see the ASCO and ESMO guidelines, there is some medications that are prevent and the therapeutic role of mucositis. First of all, I want to mention from dexamethasone mouthwash, it is commonly used to decrease the oral mucositis. Number 2, there is some recommendation also of oral antibiotics, antifungal lozenges like metronidazole, fluconazole, and doxycycline lozenge formulation. But unfortunately, it is not available in India. But if we see the UK data as well as the other guidelines, they clearly mention that these kind of things, these lozenges with antifungal and antimicrobial combination sometimes helps and prevents the confirmed mucositis grade 3 and above. And in our clinical practice, we used boroglycerate paint like glycerin, metronidazole tablet, fluconazole tablet, and doxycycline tablet. 3 tablets should be rinsed in a glycerin or honey, and this can be used as a toothpaste-like things. It is very useful. I'm really speaking. It is very useful for prevent as well as therapeutic for grade 3 mucositis when there's patient unable to eat foods and these things. These are number 2, and number 3 is regarding I heard the discussions regarding the transplant, like post allogenic or regarding the autologous stem cell transplant. We have an experimental data of resveratrol proper that is used to prevent the oral mucositis in post-transplant settings, particularly when the induction regimen was completed and patient before transplant, the conditioning regimen, basically melphalan-based regimen, they are used notorious for the grade 3 and grade 4 mucositis. And we have tested in ACTREC and TMH, the resveratrol proper is very effective to prevent these kind of mucositis post-transplant, pre-transplant setting, as well as induction therapy. So this is another thing from the medicological aspects. And if patient is having grade 3 mucositis and these things, we are already discussed the alcohol-free mouthwash, Benjamin used dexamethasone, as well as gargling and this kind of fluoride toothpaste, everything. But sometimes patient needs injectable antibiotics, gram-positive and gram-negative coverage to prevent the secondary infections. So that is important to prevent mucositis. So that is my input from all the above nice discussions. and other things is very nicely taken in all the aspects. And multidisciplinary approach is very almost known to prevent mucositis and all oral complications to prevent in this oral cancer.
Yeah, Dr. I'll invite Dr. Pavan, also Dr. Pavan Gupta, to give some comments on discussion on oral complications of cancer care.
Well, thank you, Dr. Manoj. It has been a very nicely discussed and a very nice panel. We had got people from all disciplines. We had medical oncologists, we have got dental medicine, we have got dietitians, we have got surgeons. So it is a comprehensive way of approach. That is what is important, right? And this is the purpose of our Oral Oncology Connect program, where we need to connect with each other. We should not be working in silos and just doing whatever we want. See, every person is important in the management of oncology. The dietitian, I think, holds the most important role, because if there is mucositis and all the things, if the diet is not good, nothing works, right? So dietitians and the dental experts, the oral experts are the most important part, or the entire team that should be managing these patients. So I think very nicely put, and thank you so much for the wonderful panel. I think it has been a really great learning for everyone who has been here. Thank you.
Thank you, sir. Thank you, Dr.
Thank you, my panelists. Thank you. Over to you, Shruti.
Yeah, thank you so much, everyone. Once again, I think the day went very well. Wonderful discussions. I think we had a lot of insights about different aspects. I think I have also learned a lot about patient management. Thanks to all our panelists, our chairperson and our moderator for having this extensive discussion out here. Now let's move ahead, and I would like to invite our academic
Thank you.
Kumar. Yeah, I would like to invite our academic director, Dr. Inar Kumar, to talk about what are we doing at ICanCaRe for building capacity and to ensure that we actually tame this king of cancers in India, which is oral cancer. Ma'am, over to you.
Thank you, Shruti. So before I even describe our academy, let me tell you something, that this evening has been an amazing evening. And what we have kind of gathered is actually what is really required. One is expertise from all dimensions and all directions. A multidisciplinary approach is what we need to, and we need to be all on the same plate, as rightly put by Dr. Pavan, that not on silos. We need to be together. And that's where the connect lies, the oral oncology connect. The connect is the big thing. And not just connect, is also talking and communicating correctly, just for the only one reason, that is the best outcome of our patients. Dr. Manoj, you brought out a fantastic, introduction to the whole session, and also closed it beautifully with a wonderful panel discussion with great learnings. And the prosthodontic part of it, yes, we could probably, there's lots that our prosthodontists can do in this, that we have still got to play a role in it, in total rehabilitation, because our patients here are not just facing the I think Dr. Sudha put it very nicely, the trauma, the psychological and the psychosocial aspects of it, of coming to terms with the so-called terminal disease, and also on that facing a facial deformation, a functional deformations, functional disabilities, and all of that. And we need all of us to be at our best, take in the best technology, look at whether we can use digital workflow in the later stages of life and actually work together so that we can rehabilitate the patient even before we start using the knife and cutting the patient. So now today on our academy, Shruti, the slides have gone. So as our academy, though I don't need it, so the academy, we do build, we build capacity, because we believe that at ICanCaRe, that's, of course, with the human papilloma virus out there, but yet at the same time in India being a setting that we are in, and the use of tobacco, especially SLTs, amongst the population which is there, and also the use of the newer modalities, though they are banned, but yet the youngsters are using it. So we really need to kind of spread awareness, create education, close the gap, and build capacity in all forms. So at our academy, the two flagship courses, we are fortunate to have the Gujarat University, a state university, who's accrediting our courses. So we have the specialist course, which is our flagship course, which we call the CTCS, Certified Tobacco Cessation course. It's an 8-week program, and it is a continuous program of great learning with interaction, of course, pedagogy and role plays and understanding how to communicate, how to talk, how to actually get into the patient's mind, and how do we move the patient, and the entire protocol, which is with a digitized, validated scientific protocol that we have, with the help of an ICanCaRe app that we have, a wellness app, which helps the patient, which helps the doctors, and of course, the counselors. We have the ambassador program, and we have trained, sorry, before I go ahead, we have trained about nearly 400 specialists, and from all disciplines, not just dental discipline, but we have people trained in from every discipline. And we're fortunate to have gynecologists and pediatric dentists and pediatricians who have joined our team and have understood their role in capacity building and in actually being that very niche position where they can bring about tobacco cessation and also make sure that the patients are smart and do not start. They are actually smart and do not start, and playing the relevant role. The ambassador program is also a Gujarat University certified program, and it is a program which is a 4 weeks program. It's a 1 month long program, and we have that on every monthly basis. And we are currently very thankful to Bajaj Electrical Foundation, who has recognized the need for such capacity creation and for building and for bridging the gap, that they have sponsored our program, and we have received a grant to ensure that we are able to work on this. Our program, which we are very proud of, is our Marshall program, because this Marshall is something that, it is everybody who has, we all have a role to play in the SDG goals, where we are looking at goal number 3A, and we are actually having a role in whether it is tobacco cessation, whether it's tobacco control, whether it is we are looking at how we are going to sensitize everybody, because when you sensitize youth, you sensitize women, you sensitize corporates, you sensitize, and you are kind of building people, a whole team and whole army. We have 1,000+ marshals already trained, and we have many more coming up, with an every month training planned out in the scheduling. So this is our along with this, we also have many smaller programs, which are skill up programs as the requirement is needed or expressed by people. We do skill up programs. We have our ICanCaRe tutorials, wherein everybody is allowed to bring in their cases, discuss, and actually brainstorm and come together and understand how we work towards that. So, and in addition, we have these various courses that we are, and these learning webinars and these conclaves that we have, which continues to be a continuous learning process. The certificates are fantastic. They come with a Gujarat University certification. And of course, the Tobacco Marshal is a wonderful program of ours, which moves ahead. TrisCare. Today, I think we have kind of understood that the role that this particular research product, which has come out from Dr. Pawan and from Gujarat University, have actually worked together, where we have put all our head, heart, and soul into it, such that to create something which is easy on the patient's pocket, hygienic, easy to carry, and we have been making iterations in that. There have been modifications happening in this, such that we are understanding what is it that is required to change in it, and it is very easy for the patient to carry around with it, calibrate it, look at it, and clean it and use it. It's a personalized item. It is almost like a spectacle, you see. It is your own. It is not something which is you need to kind of procure it from the market for every time that you have to use it. It's a great exerciser. I have heard a lot of concerns about the TMJ here expressed by certain colleagues of ours. Yes, the TMJ is definitely a concern, but the question comes is, how are we evaluating our patient on the TMJ before we are actually starting out these patients? Because there are certain pre-preparations which we have to do for our patients. We just can't take a product and put it in the mouth. We'll go in for further discussion, and we are open and happy to have any kind of a research program that you would like to start out, because we have always opened it up, saying that Gujarat University is happy to collaborate. And if there is a real-time research need which is felt by our by the team, of course we are ready. So please come forward, bring out your research ideas, and let's work together, collaborate with Gujarat University, and let's take this ahead, such that not only can we benefit and improve our TrisCare, but also our patients learn and we are no longer fearful of what is happening to the TM joint and various other concerns. Thank you so much for being here. It's been an amazing evening, truly. And I think today what we have learned has put a lot of things that we as dental surgeons, just cannot take it as that we are drill, frill, and pack up and implants and that's it. No. And as an orthodontist, because there was a question by Dr. Manoj, so I would like to just address that question because I'm an orthodontist. So patients who are on bisphosphonates, obviously we cannot do orthodontic treatment for them because they are going in to go for root resorption because the bone is not amenable to any kind of, angiogenesis there, and there is no movement of the root which is going to happen. So we are going to end up losing the tooth. So in such patients, there are different modalities by which we can do the treatment after a certain period, after the half-life, and then we kind of have to put very light forces, extremely light forces, maybe where we would move 6 teeth together, we would move 1 tooth at a time. So Dr. Manoj, please excuse me for bringing this in, though I was not on the panel, but I thought as an orthodontist, I would like to contribute that part of it. It's been great having all of you here. And thank you so much. Let's meet again next week. We had a wonderful student session yesterday. We encourage, there were a lot of young researchers, and we thank all the mentors who have, worked with their mentees, and they all came in, and we had even people as first-year BDS students who brought out beautiful papers yesterday, and they were really nice. So we encourage all of you to encourage your young researchers in your organizations to come forward in our next conference, which is going to be in July, and make the paper presentations. And we will announce that ASAP, probably in another week's time, we will announce that. Thank you so very much. And thank you, everybody, and have a great evening.
Thank you.
Pavan sir, you're on mute.
My request to everyone is that please let us remain connected. And after this wonderful discussion that we had on the panel discussion, I think it is important that we form some protocol, we form some system, and we form some learning platform where we can learn from each other. And definitely this will go a long way in improving the quality of life of what I call the king of all cancers, that is the oral cancer, right? And not only oral cancer, but oncology as such, because oral cavity is the most important that needs to be taken care. So before we leave, I request everyone, I've just shared the link on the chat box, the Facebook page. I would request each one of you, all our panelists, all our faculty, and those who are there still as a participants, please do click on the link and join the Facebook page, because we'll be declaring the results. We continue to have a lot of interaction on the community page. So can I request everyone to join in there? Click on the community page link and join the page. Yeah. I can see some of you have already joining there. I think that's great. I can find some of you requesting for the yeah. So I think we will stop here, and we look forward for your for the next important event, that is on next Sunday, where we will have the final event, and where we will be discussing, declaring the results of the paper presentations, of the quiz, and also for those who have been the winners for every day. So thank you, and over to Shruti for the.
Yeah, thank you so much, sir. I think we have been a fantastic audience. To all our viewers on YouTube and Facebook, I'll request, please put down your full name and email address on the chat box of Facebook page of ICanCaRe, so that we can send out the participation certificates to you. For all others on Zoom, we already have your credentials, so you'll receive it shortly once we finish the valedictory on 30th. I invite all of you to join us on valedictory for 30th for valedictory session, and on 30th of April, which is next Sunday, at the same time, 3 p.m. and the valedictory starts at 5 p.m. So hoping to see you soon, everyone. Have a great Sunday. Have a great week ahead before we meet again next time the next week. Thank you so much. Have a great day. Bye-bye.
Mahbooba, thank you for being there.